Dr. Sudhir Chand Jha is our next speaker. He will be speaking on early combination therapies in type 2 diabetes, which is a very important topic. And Dr. Sudhir Jha is well known for the Bihar. He is associate professor in Department of the Medicine at Darbhanga Medical College. He is secretary API Darbhanga branch, zonal member of CCDSI. He is chairman of the scientific committee RSSDI BIHAR chapter, publications in index journal, and he is noted speaker on state and national forum. Dr. Sudhir Chand Jha. Over to Dr. Sudhir.
Honorable chairpersons, respected seniors and colleagues. Firstly, I will congratulate Team Bhagalpur for hosting such a wonderful conference, and thanks to them for providing me this opportunity. In the next few minutes, we will be talking about why early combination therapy today in type 2 diabetes mellitus has become important, and it is the time to go for early combination rather than standard of care stepwise addition of molecules. Yes, today the world is facing the tsunami of type 2 diabetes mellitus, and most of this tsunami is occurring in the middle and low income countries like India. Number has become 4 times in last 3 to 4 decades. What is very ominous, that type 2 diabetes is a chronic, relentlessly progressive disease associated with multiple complications that not only reduces the life expectancy but destroys the quality of life. Can we believe that in India 1 million persons are dying because of diabetes, and it has emerged as a major cause of blindness, stroke, heart attacks, kidney failure and lower limb amputations, putting a huge socio-economic burden on individual, family and the society. Hence the need for early and intensive control. This slide reminds us how uncontrolled diabetes damages different systems of the body: brain, teeth, nerves, eyes, heart, kidneys and whatnot. This slide is perhaps the most important slide in understanding the pathophysiology of type 2 diabetes mellitus. By the time diabetes diagnosis is made, 50% or more of the beta cell function is already lost. The patient has already some of the complications to start with. So you can see from this picture that the onset of type 2 diabetes mellitus, this beta cell decline, has occurred 10 to 12 years prior to the diagnosis of type 2 diabetes mellitus. And even after the diagnosis, this relentless decline goes on, and our job as a clinician is to slow down the decline, if not totally prevent it. Our understanding of pathophysiology of type 2 diabetes has improved immensely from triumvirate previously, which means that previously we used to believe that pathophysiology lies in impaired insulin secretion, increased hepatic glucose production and decreased glucose uptake in the muscle, to now famous ominous octet by Diffranzo in 2009 in creatine, glucagon, insulin, neurotransmitter dysfunction, increased lipolysis, decreased peripheral glucose uptake and increased glucose renal absorption and increased hepatic glucose uptake. So all these 8 pathophysiology is said were involved in type 2 diabetes mellitus. So what is the implication? The implication is that we need multiple drugs to address the multiple pathophysiological defects. And intensive therapy must be started early on if progressive beta cell failure is to be prevented or slowed down. This is the distinction between a stepwise therapy which we have been practicing since long, lifestyle modification, metformin, no control at another molecule, no control at another molecule at periodic intervals. Potential advantage was that good patient adherence with stepwise therapy, cost was less, easier to assess efficacy and side effects, and easier individualization of therapy. But what were the risks? The risk was the prolonged hyperglycemia and subsequent complications, an increased risk of clinical inertia. And in combination therapy, use of combination is aimed at targeting multiple pathophysiological mechanisms, preferably by complementary modes of action, an earlier and greater achievement of glycemic goals, potential delay of disease progression and preservation of beta cell mass, reduction in clinical inertia. However, it has got certain disadvantages too, like assessment of efficacy side effect becomes very difficult, and long-term cost effectiveness not easily assessed in absence of comparative efficacy studies, and patient adherence with complex multiple drug regimens are a problem. Now, earlier and appropriate intervention mean improve patient chances of reaching the goal. We can see that published conceptual approach, diet and exercise, OAD monotherapy, OAD up titration, OAD combination, OAD basal molecule, and then you multiple daily insulin injection. The blue graph shows the glycosylated hemoglobin goal, and the yellow line shows when we go for early combination therapy, and difference is loud and clear. Fortunately, we have got many molecules. When we were students, we had 2 or 3 molecules, so there was no possibility of doing much. Now we have got so many molecules around that we can go for proper combination with complementary modes of action, resulting in improved target achievement, weight reduction, reduced risk of hypoglycemia, delays disease progression, blood pressure reduction, improved glycemic control long term, and reduced long term diabetic complications. So choosing treatment options, we have many, and what is very important, that each oral molecule has got the limitation as far as reduction of glycosylated hemoglobin is concerned. So don't forget the insulin, which has got the unmatched efficacy of glycosylated hemoglobin. Now here this slide shows how combination of SGLT2 inhibitor and DPP4 inhibitor can work, good work as far as controlling hyperglycemia plus providing pleiotropic effects are concerned. SGLT2 inhibitor working on the unique mode of action by promoting glycosuria, blocking the absorption of glucose from proximal convoluted tubule, and while DPP4 inhibitor has got dual pancreatic effect, glucose dependent insulin secretion, reducing the secretion of glucagon, and it has got the incretin effects as well. Now this is a very important slide. Now legacy effect, all of us know metabolic memory legacy effect. The earlier you control the glucose, that benefit goes on and on. In the subsequent period of time, we see lesser complication and more benefits, even though the glycemic control may not be that particular. This legacy effect is possible even in the advanced effect of in the advanced stage of type 2 diabetes mellitus. If we control the glucose, they are going to have the benefits, but of course with the associated complications. But when this is tried early on in the type 2 diabetes mellitus, the huge beneficial impact is there. The studies from Wikipedia, what they are suggesting, that intensive approach is associated with reductions in long-term diabetes complications. See, there is whopping 43% reduction in lower extremity amputation or fatal peripheral vascular disease, 37% increase in microvascular disease, 19% reduction cataract, 16% reduction heart failure, 14% reduction myocardial infarction, and 12% stroke. Amazing beneficial effects. So, if you want to know the impact of intensive therapy for diabetes, this summary of major clinical trials is very important one. We can see that all these major studies, UKPDS, DCCT, EDIC, Record, Advanced VADT, they showed a tremendous reduction, in significant reduction in microvascular complications, and in 2 of the studies This was apparent in the long-term follow-up as well. Though this effect was less apparent on the CVD, though in UKPDS and DCCT in the long-term follow-up there were cardiovascular benefits as well. Mortality part in UKPDS, it showed in the long-term follow-up slight reduction in mortality, whereas ACCORD, it showed increase in mortality. That may be because of the factor that the glycemic goal was 6 as compared to UKPDS where it was 7. Now this present clinical inertia, this slide will show the inertia. Now this Discover study is a global prospective non-interventional study conducted at 38 countries across 6 continents, and the study was has enrolled 15,000 patients and followed up. Now out of this, Indian arm consisted of more than 3,000 patients, and what was the mean glycosylated hemoglobin at the outset? Even after this 8.6% was the glycosylated hemoglobin to initiate second line of treatment. Before initiating second line of treatment, glycosylated hemoglobin was 8.6%. So you can see the inertia. 45% patients controlled with metformin and 32% uncontrolled with metformin and sulfonylurea. And what is very important, that patient remain on multiple oral therapy for too long, and there is no harm in initiating insulin if you are unable to achieve the glycosylated hemoglobin goal. This combination therapy is more rational in Indians because Asian Indians are 3 to 4-fold more insulin resistant, and beta cell responsiveness is less, and we lose beta cell function early in the course of disease. Now this Korean nationwide cohort study of around 25 lakh adults, individuals with newly diagnosed diabetes and pre-diabetes, showed increased incidence of CVD and all-cause mortality risk. And individuals with early glycemic recovery from diabetes or pre-diabetes had decreased incidence of CVD and all-cause or cardiovascular mortality risk. Then came this was the first trial which demonstrated the glycemic durability of early combination therapy with Vilda and metformin versus sequential metformin monotherapy in newly diagnosed type 2 diabetes mellitus. 34 countries, 254 centers, 2001 people. And this was the design screening period of 2 weeks, run-in period of 3 weeks of metformin monotherapy. It was divided into 2 arms. In one arm, metformin twice daily plus Vilda was there, and in other group, metformin group was there. And if the metformin mono group did not achieve the glycosylated hemoglobin, only then the Vilda gliptin was added and the period 2 is started. And in the period 3, the intensive treatment was done to achieve the goal. These were the inclusion criteria. BMI 22 to 40, 18 to 70 years, and what was very noticeable that glycosylated hemoglobin was very low, 6.5 to 7.5%, and this showed that median time to initial treatment failure and early combination therapy significantly reduced the risk of time to initial treatment failure by 49% as compared to initial monotherapy strategy, and median time to failure was 3 years in mono group, while it was over 5 years in the combo group. Another study added, it showed the patients were divided into 2 groups. One group was given metformin, pioglitazone, exenatide, the drugs which are mostly concerned with the sensitization, insulin sensitivity part. Another group was the sequential addition of metformin, sulfonylurea and glargine, which were basically concerned with controlling blood sugar. And what were the result? The better long-term 2 years glycemic control in the combo group, it was 5.95% as compared to in other groups 6.5%. And what was very amazing was that lower hypoglycemic rate was there, 7.5-fold lower rate. And it also had weight loss of 1.2 kg versus 4.1 kg weight gain in the metformin, sulfonylurea, glargine group. Now, this was a randomized trial of 58 patients with treatment-naive, newly diagnosed type 2 diabetes. All patients were treated with insulin and metformin for 3 months, and then it was divided into 2 groups. One group continued with insulin and metformin, and other group was given with this triple oral therapy. and they were periodically assessed. And beta cell function can be, what it showed, that beta cell function can be preserved for at least 3.5 years with early and intensive therapy with either insulin plus metformin or oral therapy after an initial period of 3 months insulin based treatment period. So the control matters. Early combination therapy, what does ADA and ACE says at this point of time? ADA, the glycosylated hemoglobin goal is less than 7%, while in ACE it is 6.5%, and in certain circumstances it can be variable, and treatment depends on the glycosylated hemoglobin at the level of diagnosis, while ADA recommends monotherapy, usually metformin, if glycosylated hemoglobin is less than 9% with a stepwise addition of anti-hyperglycemic addition to dual or triple therapy at 3 months interval until patient is at goal. But combination therapy, if glycosylated hemoglobin is more than 9%, and dual therapy should be recommended to start with, and if glycosylated hemoglobin is more than 10%, then in that case combination injectable therapy should be promoted. And AACE, what it recommends? It recommends monotherapy, preferably with metformin plus lifestyle modification if glycosylated hemoglobin is less than 7.5%, followed by therapeutic intensification due to dual or triple therapy at 3 months interval until patient is at goal. And combination therapy if glycosylated hemoglobin is 7.5% or more. And if it is more than 9%, then insulin and other drugs should be. So the message is glycosylated hemoglobin more than 1.5% above target. So taking the clock is ticking. Microvascular complications, the clock has started ticking at the onset of hypoglycemia. Macrovascular complications even before the diagnosis of hyperglycemia. Early intense performance win matches both in cricket and diabetes. So friends, the message is very clear. Type 2 diabetes is a chronic, progressive, relentlessly losing beta cell disease with multiple pathophysiological factors resulting in multiple micro and macrovascular complications, putting a huge socio-economic burden on the society. Early combination therapy with complementary mode of action not only addresses multiple defects but provides the benefit of legacy effect. An intensive approach is associated with reductions in long-term diabetes complications. Early combination therapies represent new era of early detection, diagnosis and management to prevent and slow down the progress of the disease. Thank you.
Hello, yeah. Congratulations, Dr. Sudhir Chandra. As usual, excellent deliberation, and the topic, that's your choice, that is upon the diabetes, and the very important message that you have conveyed, that the early combination therapy, this is the era of early combination therapy, as in other diseases also, whether it is hypertension and other things. So, but what is the choice of the drugs combination and level? You have already told, just the message wise, which level HbA1c, and then the combination, ideal combination that you choose, that what is that? Thank you.
At the moment I will say that recommendation of ACE is very important, and if the target goal is 1.5 or more above the glycosylated hemoglobin, that should be followed. Lifestyle modification remains the cornerstone of the therapy, no doubt about that. And after that, we should choose the complementary mode of action. Today we are talking about ominous octet, maybe tomorrow we will be talking about dirty dozen, and maybe sweetening 16 or troublesome 20. One thing is very clear, treatment of type 1 diabetes is simple, treatment of type 2 diabetes is complex. So we have to put our mind, we always imagine that someday we should have a molecule which will protect the target organ as well.
So
fortunate.
So there is straightforward answer. Combination of this 1, 2, 3.
Yes, sir. I'm just pointing that out. We are lucky to have SGLT2 inhibitor and GLP-1 receptor agonist, which is cardio, renal, and metabolic protective. And so this even ADA is coming up that if there are issues, then ahead of metformin you can go for these molecules. So each case is different, and there is one size doesn't fit all. Individual characteristics are there. Before 2018 it was glucocentric approach, today it is patient-centric approach, and this should be decided. SGLT2 inhibitor and GLP-1 receptor agonist in particular, they have changed the paradigm of the treatment of type 2 diabetes.
Thank you. Any questions from the audience? There is no questions because you have given such an elaborate talk. Thank you very much, Dr. Sudhir.
Thank you, sir.
And now we shall invite one of the topmost diabetologists of India, Dr. Anil Kumar Virwani, National Executive Member and whatnot. And we have listened to him many times. Let's just enjoy the diabetology, that is the acute complication of diabetic mellitus.
Yes.
Over to Dr. Virwani.
Honorable chairpersons and dear friends, again it's an honor to be here in JLN Medical College, Bhagalpur, to give this talk. Not working? Okay. The topic is acute complications in diabetes. What's new in 2023? Now you must be wondering, why this topic? Everybody knows what are the acute complications in type 2 diabetes. And when I use the word what's new, it can mean two things. Either something is really new, and that is not surprising because we are rapidly advancing day to day. Every day morning we get up, we realize that we have learned something new. And number two, it was there already, but it was at the back of our mind, and now it has been brought to the center stage by the guideline making authorities. And that is the meaning of new, and that is what I'm going to talk about. But just to revise, what are the acute complications? We know one of the commonest is hypoglycemia, 5.4% of the total hospitalizations. Then we have diabetic ketoacidosis, and the search study showed that 29% of the patients aged less than 20 years with type 1 diabetes and 10% with type 2 diabetes presented with DKA on diagnosis at the first time. Then we have the rare 2 hyperglycemic hyperosmolar state less than 1%, and lactic acidosis around again 1 to 1.2%. Now we know all these 4 complications are theoretically preventable. Unfortunately, they still account for enormous morbidity, hospitalization and mortality with high cost of diabetes care. Now let me start with hypoglycemia because, as I said, this is the commonest and this is one of the most important, and we have really learned something new in this. One of the biggest things we learned earlier, we did not know, there was a lot of confusion. When do you call a person going into hyperglycemia, at what level? Yeah, please. And then we have now come to the clear classification, and there's a consensus statement by both the ADA and the European Association of the Study of Diabetes. Level 1 is glucose less than 70 and more than 54. And what is the rationale of putting that figure 70 and 54? Because that is the threshold for neuroendocrine response to falling glucose in normal people. Clinically important, independent of symptom severity, because many patients have hypoglycemia unawareness. And biggest thing, it provides a margin of safety and allows time to prevent progression to a clinically hypoglycemic state. Then we have level 2, a sugar of less than 54. The rationale for that is when the neuroglycopenic symptoms begin. And resolution of hypoglycemia requires immediate action. That's the red signal. Go act, otherwise you're going to lose this patient. And level 3,
A severe event characterized by altered mental and or physical status requiring assistance for the treatment of hyperglycemia. You need a third party to treat the patient. And the rationale is here the consequences can be deadly unless a third party is available to treat the hypoglycemia. Now, I will not go into the various symptoms. You all know there are neurogenic symptoms, there are neuroglycopenic symptoms, nothing new in this. Severe and prolonged hypoglycemia we know leads to seizure, loss of consciousness, coma or death. And there is acute harm to self and others, vehicular accidents, traffic accidents, etc. And severe hypoglycemia has also been associated with increased mortality in the acute, advanced, and even in routine clinical practice. And there is also sufficient evidence to say that severe hyperglycemia can lead to cardiovascular disease. So we all know this. But what is new? Mild hypoglycemia. We never bothered about it earlier. But today we know that it can induce defects in counter-regulatory response and lead to impaired hypoglycemia awareness. This is a study of more than 77,000 patients where mild hypoglycemic episodes were associated with subsequent cardiovascular disease hospitalization, CSD, stroke, and all-cause mortality, and of course loss of productivity. With the advent of CGM, we learned that there was unknown, hidden, sinister, minor hypoglycemic episodes occurring. And we started recognizing these hypoglycemic episodes after the advent of CGM. And it has been shown in the study that with glucometer, 10% reported a level of 2 or 3 hypoglycemia, but with CGM, 42% had a sugar of less than 54 and 18% less than 40 milligram. And this we were missing earlier. This is another trial which showed that 75.4% were not aware of the hypoglycemia that was detected on continuous glucose monitoring. This is a very interesting paper just published two days back by Manoj Chawla et al. And this is a retrospective CGM study. And what did they diagnose? Even if your A1C level, we know that A1C level below 7% means intensive control, so there is bound to be hypoglycemia. But even with the A1C level of more than 8% or 9%, there was a very significant number of people who had time below range. So they were having hypoglycemic episodes. And these hypoglycemic episodes were leading to cognitive dysfunction and early dementia. So what's new in hypoglycemia today? The current recommendations are you must review at every encounter with the patient. And you must treat with fast carbohydrates, and treatment all of you know very well. Don't give protein because it may increase insulin response without increasing the plasma glucose. You basically have to give carbohydrate or glucose containing foods. Even don't add fat because that can prolong the glycemic response. All of this is very well known and written in the books, and all of you are treating hypoglycemia. I will not go into this detail. The other thing is the importance of glucagon has come up like anything. And now it has been recommended that glucagon should be prescribed for all individuals at increased risk of level 2 or level 3, and it should be available when needed. And you don't need only the patient, anybody can inject, whether it's a school personnel, family member, anybody who's there can give the glucagon, and it is not limited to health persons. Now, something about glucagon, we know it's the main counter-regulatory hormone to insulin, and it is the first response in insulin-treated patients. 1 milligram of dose is reconstituted and given subcutaneously or intramuscularly. Nowadays, pre-prepared doses are available, which are much better, and it basically acts to maintain glucose production through glycogenolysis and gluconeogenesis. It's a very short half-life of hardly 8 to 18 minutes. Now, we are treating with parenteral glucagon patients of type 1 diabetes, but when we are treating severe hypoglycemia in type 2, we give IV glucose especially those who are on sulfonylureas. And it is very important to realize that patients who are on sulfonylureas should not be treated with glucagon, but they should be treated with IV glucose, because otherwise they'll have further increase in the insulin and hypoglycemia will form a vicious circle. Now, latest we have the nasal glucagon, first nasal glucagon that has been approved by the FDA. So it is even better than an injection to treat hypoglycemia. Another very important thing that has come up is hypoglycemia unawareness. And that means that once patient develops this, he needs to be re-educated and adjustment of treatment plan. And because patient is having hypoglycemia unawareness, it means he is having repeated episodes of hypoglycemia, so cognitive function should also be tested. Now, it reduces basically, there is a reduced intensity and number of symptoms, there is a change in the symptom profile, and there is a threshold for hypoglycemia is set at a lower level, and the adrenal response is diminished, and it is also known as hypoglycemia associated autonomic failure. Now, how do you manage this patient? You increase the frequency of testing of blood sugar, increase the frequency of snacks, and the patient should consume regular snacks between meals. The first goal is avoid all hypoglycemia for 3 days. That is when a pattern starts to emerge in relation to therapeutic response. The second goal is to avoid hypoglycemia for at least 3 weeks. And this is associated with the recovery of hypoglycemia unawareness and counter-regulation, except in those who are having autonomic neuropathy, where it may take 3 to 6 months. And then we have to revise our blood sugar targets to higher levels. That is very, very important. So strategies to reduce hypoglycemia in this era of digital technology, we need clinical decision support tools. We need system support, we need social support, we need clinical support, we need policy support. And all these have to be amalgamated in daily clinical practice to avoid hypoglycemia unawareness, repeated episodes, cognitive dysfunction, cardiovascular disease, etc. Coming to DKA, 3 things are required to diagnose. The D, that is a blood sugar concentration of more than 200 or non-diabetic. The K, ketone concentration of more than 3 millimoles or significant ketonuria. And A or acidosis, a bicarbonate concentration of less than 15 milliculons. Of course, the ADA uses a slightly different definition. They also include the anion gap. At the time of diagnosis, the DKA is caused by underlying progressive beta cell failure in previously undiagnosed type 1 diabetes. In established type 1 diabetes, it's basically because of insulin omission, inadequate insulin dosing during infections, GI illness, gastrointestinal illness, trauma, stress, pump failures today in the era of insulin pumps. And type 2 diabetes, it is basically associated with concomitant acute illness or when you are switching therapy or transition to insulin dependency. So what's new in DKA? You must be wondering what's new. We all know that ketoacidosis remains a potentially life-threatening condition. And now we have realized that there is increased prevalence of hypoglycemia and hypokalemia during the DKA. And so there were certain changes that were recommended in the how way we should treat. The updated guideline now recommends once the blood sugar falls to less than 250, remember this was 200 earlier, decrease the insulin infusion rate from 0.1 to 0.05 units per kg per hour. And this is something really new that we have learned. And we also know that venous blood gas, measuring capillary ketone, just like we measure glucose, are now keys to guiding the management of ketoacidosis. And then certain new things we have seen, they were there earlier, euglycemic ketoacidosis, but they have come up to the forefront, ketosis-prone type 2 diabetes, and those associated with renal dysfunction. So blood sugar, we have already been testing in the using point-of-care testing meters, but now we have portable ketone meters. Staff has to be trained in these ketone meters. you have to maintain rigorous quality assurance, and you need to know when these ketone meters can go out of range, and you must know, staff should know what interference can take place, especially when there is peripheral shutdown and shock, and then you have to go to laboratory value. The normal levels of beta hydroxybutyrate on these ketometers can be defined as less than 0.6 millimoles, 0.6 to 1.5 is ketosis, 1.5 to 3 is hyperketonemia, and more than 3 is ketoacidosis. Now there were some certain controversial areas in DKA that have now been resolved. When I was in the ICU, in charge of ICU way back in 84, 85, we used to do arterial blood gas to find out the patients with DKA, to get the blood gas analysis. But today, it's recommended you don't have to go for arterial. It's cumbersome, and venous is not as bad. So venous, today is venous. We never had blood ketone meters at that time. Today they are available. 0.9% sodium chloride still remains the recommended fluid of choice in the medical ward. And the patient is on a long-acting basal insulin, it should continue. And insulin today should be admitted as a fixed rate IV insulin infusion. Fixed rate. And I'll stress that. Do not use a primary bolus dose. I remember I used to give bolus dose of 15 units, 20 units before starting the insulin infusion, because it increases hypoglycemia and doesn't have any other clinical benefit. Now this is one wonderful case I want to talk about, and I'll take 3-4 minutes more, sir, if you don't mind. A 21 years old lady with history of type 1 presents with DKA, sugar 300, pH 7.25, potassium 3.3, bicarbonate 14, and beta hydroxybutyrate 4.5. So this is clearly DKA. So what is your next step? Will you start insulin, bicarbonate, potassium, or phosphates? Anybody? Potassium. Excellent. So we know that patients with DKA have total body potassium depletion, and when you start insulin, potassium is further shifted, and patient can go into severe hypokalemia, and there is cardiac arrhythmia. So next question is how to start. As a thumb rule, 10 milliequivalents of potassium given should raise it by 0.1 milliequivalent, but extremely low potassium levels, this rule does not apply. So best is to monitor all patients with ECG, and then you give accordingly the potassium. And in this, our patient who had a potassium of 3.3, 40 milliequivalents is required minimally to start with before you start insulin infusion. So after starting IV fluids, the next step in DKA management is electrolyte replacement, not insulin. That's a very, very important thing you must realize. And of course, the general management issues, fluid administration and deficits. Insulin therapy, as I said, I want to again re-emphasize, is a fixed rate intravenous insulin infusion, no bolus, no sliding scale. Metabolic treatment targets are very well recommended, and they are the same. I'll just take 2 minutes more, please. The main aim of treatment is suppression of ketogenesis, reduction of blood glucose, and correction of electrolyte disturbances. And you have to be careful in certain subgroups like elderly, pregnancy, young people, heart or kidney failure, or other serious comorbidity. So to summarize, what's new in DKA? Crystalloid rather than colloid solutions are recommended. Initial fluid treatment is 0.9% sodium chloride. Once the sugar falls to 250 mg% or less, decrease half the dose of insulin infusion. Cautious fluid replacement in young adults. No use of routine bicarbonate therapy or phosphates. And the rate of glucose lowering should be around 54 mg/h. Euglycemic ketoacidosis is something that has come up recently. It's a raised anion gap metabolic acidosis, ketonemia, significant ketonuria. Patients on SGLT2 inhibitors have brought this forward, but it was there earlier. It was seen in pregnant adolescents, very young and partially treated children, and children fasting during a period of insulin deficiency, but we never talked about it at that time. This highlights the importance of using both pH and ketones to guide the diagnosis and management instead of being glucocentric. And it is treated, you know, the treatment 10% glucose with insulin, and then you also reduce the dose of insulin later on. Now the clinical implications, off-label use of SGLT2 in 1 diabetes is to be discouraged unless you are doing a trial. Also in pancreatic secondary diabetes, syndromic diabetes, MODY, LADA should be avoided unless further data is available. It is very rare, very rare. Hardly 0.5 to 0.8 per 1,000 patient years. And it is very important to be pharmacovigilant about it if you want the advantages of blood pressure and weight gain, weight loss. And then it should be patient should be proactively educated regarding sufficient hydration, general hygiene, adequate carbohydrate intake by using SGLT2. And in sick patients who are having nausea and vomiting, you should immediately alert the clinician and stop it, even though the incidence is very low, but there is no need to measure serial urine ketone measurements. Even in patients with heart failure, the incidence is less, angioedema incidence is more. So it is there, but you must keep it in the back of your mind. Stop SGLT2, inject bolus insulin. This is the only place where you inject. Consume 30 grams carbohydrates and hydrate the patient. Flatbush or the atypical diabetes occurring in Afro-Caribbean or Hispanic descent, and this is basically, patient come off the insulin. This is unprovoked decay in association with history of polyuria, polydipsia, etc. And most of the patients will undergo spontaneous remission once you and requiring discontinuation of insulin therapy, but still 60 to 70% may relapse, so require a close follow-up. And there are no markers of immunity are seen, so it is different from type 1 diabetes. So there is basically a transient security defect of the beta cell during the acute phase, which recovers spontaneously. So how do you diagnose? All patients who present with DKA may not require lifelong insulin. Early management of atypical diabetes is similar to type 1, but a rapidly falling requirement for insulin over the first few weeks must give you a signal. This is atypical diabetes, and they don't have any autoantibodies. Hyperglycemic, hyperosmolar state, very high blood sugar, serum osmolality, absence of significant ketosis, acidosis. Here the insulin levels are inadequate for glucose utilization by insulin sensitive tissues, but sufficient enough to prevent lipogenesis and ketogenesis. And prevalence is quite high. Mortality is very high, higher mortality than DKA, and the precipitating causes are similar, infections and etc. So you require intravenous hydration. The basic difference is here, as compared to DKA, there is relative deficiency, there is absolute deficiency of insulin. This develops over days to weeks, that develops rapidly, and this is more common in the elderly, type 2 diabetics, and with a very high mortality. Lactic acidosis, again, a very, very rare disease. Elevation of lactic acid above 5 milliequivalent, acidosis, no ketoacidosis, but you must remember it. And the biggest precipitating factor is impaired oxygenation. And whatever the cause, and this is normally seen in critically ill patients, and mortality rates are very high, leads to neurological. Since it is acute, we cannot prevent it, but you must remember the only way to treat is to improve oxygenation. So friends, unmanaged diabetes is like a ticking time bomb. If you want to prevent those complications, manage hyperglycemia effectively. Thank you.
Again, the excellent deliberation by Dr. Anil Kumar Bidwane, and the message is loud and clear that especially in the mild hypoglycemia, we usually do not pick up that, and for that continuous glucose monitoring is the order of the day. And that's a very important message from you. But the DKA also, there are many things new you have, especially the level of the glucose and the dosing, that bolus, no, sliding scale, no, and all other things, hyperosmolar coma and euglycemic ketosis, everything is loud and clear, and so no question will be
I just like to add one thing. Dr. Amit Das pointed out that it's not possible to do CGM nowadays. I think it's very easy to do CGM.
Yes, sir.
The cost is only 1,000 rupees. Now five patches are available with a sensor. The sensor is costing 5,000, but you can do it in 5 patients, so it comes to 1,000 rupees per patient. and you can easily do it. You get a 14 days ambulatory glucose profile through the flash monitoring system.
Sir, nobody wants that they should have this mental, this recognition or this dementia and anything. So glucose monitoring, the continuous glucose monitoring, if we physicians, we diabetics will advocate, it will come, it will be used, it will be used by the patient. Thank you very much.
It's not available to all.
Now it's available to all, that's what I'm saying.
No, it's not available to all. The issue.
See, what has happened in the last 1 month? Last 1 month, Abbott people have distributed this kit. This kit contains for 5 patients along with the sensor for 5,000 rupees to all the chemist shops in Jharkhand. I don't know about Bihar.
The rest discussion we shall during the lunch hour. I mean, please. So from our Governor ACP, Dr. Anuj Maheshwari, Dr. Sadiq Mohammed Sadiq, the session is over. We have enjoyed, we have enriched by your talk, Dr. Anil Kumar Virwani. So we shall call both Dr. Sudhir and Dr. Anil Kumar Virwani on the desk.
Thank you, chairpersons, and thank you, speaker, for this session. May I request chairpersons to honor Dr. Anil Virmani sir with a bouquet. And Dr. Yeah, chairpersons to honor speaker. Yeah, with bouquet for Dr. Sudhir and Dr. Anil Virmani sir. Wait, okay. And bouquet. And may I request our 2 illustrious speakers to please honor the chairpersons, sir, with a bouquet. A memento for Professor Dr. D.P. Singh sir. He has not received it yet. And a bouquet for Dr. Sadiq. Thank you so much, speakers and chairpersons, for this session. Yeah, bouquet for Dr. Sadiq. There is some change in the scientific program. There is a little delay in setting up the lunch because of the thunderstorms we had yesterday. So we are preponing the few of the talks. So may I request speakers for the next session, Dr. Amit Kumar Das, Dr. Raj Kamal Chaudhary and Dr. A.K. Pathak sir to please come on the dais. And they will introduce the speaker for the next session.
Hello. Shankho is a very good friend of mine and I'm privileged to introduce him. He was our best postgraduate student and he is still the best speaker in the entire Bengal. So this is his introduction. Welcome Shankho to Bihar again. We don't feel that you are away from us. Every time we call you and you come. कभी तो मना कर दो. Welcome Shankho, and we are eagerly waiting for your nice deliberation.
Thank you, Amit. Thank you for the kind words. Being a good friend of you is a good privilege to me, and I thank the organizers, and I thank Shankar Sharma sir and Dr. V.K. Singh sir for the kind invitation. My talk today is on pre-diabetes. After all the acute emergencies spoken by Dr. Virmani and other complications which I've already heard recently, probably we have to think of some preventive strategies regarding pre-diabetes, because we know the metabolic risks. The risks are already there, which have been described by my previous speaker. So I am a physician. I practice in Shiliguri, and I convey my regards from the northern part of Bengal, being the Secretary of Association of Physicians of North Bengal. I pay my regards to all of you from RSSDI BIHAR. And it's a proud privilege also to be speaking in front of the Governor of ACP, Dr. Anil sir. It's my proud privilege. Thank you. So pre-diabetes is a pre-diagnosis of type 2 diabetes. It's not a disease. It's a warning sign. And as per ADA, it says that pre-diabetes should not be viewed as a clinical entity in its own right, but rather as an increased risk for diabetes and cardiovascular disease. So it's the state in which some, but not all the diagnostic criteria are met. It is the gray area between normal blood sugar and diabetic levels. Following at the intermediate stages, as you all know, IGT, IFG and elevated HbA1c, while pre-diabetes is associated with insulin resistance, and it has an increased risk for cardiovascular disease. So pre-diabetes, what really happens? There is loss of beta cell functions which occurs even before diagnosis, and even before diagnosis at least 50% of the beta cell is lost. So much time can be gained if we take care of the pre-diabetes stage. That is my point of discussion today. As per ADA criteria, the HbA1c between 5.7 to 6.4 is pre-diabetes. And an IGT, as you all know, is less than 200 but more than 140. And IFG is more than 100 and less than 125 as per ADA criteria, and more than 110 as per WHO and ADF criteria. So what is the point of discussion today? It's because we need to know the prevalence and risk factors, and most importantly the associated comorbidities and high risk individuals, and the pharmacological treatment, if any, is recommended along with lifestyle modification. So in pre-diabetes, the prevalence of risk factors is quite important, and International Diabetes Federation comes out with frequently with these particular statistics, and this is very important. As per 2019, India has a huge burden of diabetes. It is ranked among the first 2 to 3 countries with the highest number of pre-diabetes also along with diabetes. And the projected number is around 32.2 million of people of India living with diabetes in 7 years' time, that is 2030. And by 2045, probably it will rise to more than 40 million people living with diabetes. But as you all know, diabetes, awareness, detection, treatment, all are certain areas where we need to be vigilant. Only 50% of the patients are aware of being detected about diabetes. Among 50% of those detected are being treated for diabetes, and among them, 50% of those who are treated are in goal. So it's a huge burden to us, and particularly in our part of the world where we are having a huge diabetes burden. It's almost a tsunami. So the projections are quite scary, and for this we need to be aware that what pre-diabetes is, and it will progress to type 2 diabetes in approximately 25% of the patients within first 3 to 5 years, and around 70% of individuals with pre-diabetes will develop diabetes within their lifetime. There are various studies done by ICMR, India Diabetes Study and all, which was conducted in 15 states, and all those showed quite a high prevalence of pre-diabetes at around 10.3%. Pre-diabetes may, however, be reversible through implementation of lifestyle modification programs based around the adoption of healthier diet and increased levels of physical activity. The overall prevalence of pre-diabetes was around 10.3%, and age, male sex, obesity, hypertension, and family history of diabetes were independent risk factors. And prevalence of impaired fasting glucose was found to be higher compared to impaired glucose tolerance. These are some important factors which are important to us. And very importantly, India has more than 50% of its population below the age of 25, and more than 65% of the population below the age of 35. And compared to China and Japan, where the average age is around 37 and 48, but in India the average age in 2020 was around 29. So highest number of young age population is in India, and an NCAR study showed that Surat had a percentage of around 74% of people living with below 35 years of age. Similarly, Delhi around 70%, Lucknow around 68.8%, and so on. So India is a young country, and earlier onset of diabetes is a risk factors more compared to Caucasians because of the genetic predisposition, high levels of obesity and physical inactivity. And Indians are considerably thinner but more centrally obese compared to Caucasians. So despite being lean, Indians are more insulin resistant and hyperinsulinemic. So these are the important statistics, and there are various studies like the Stride Eye studies and all these which are done in various areas, including the rural areas in India, and even in rural areas there was an increase in abdominal obesity. The ADA has in 82nd session of ADA, also there are studies which are presented on the effect of age on risk relationship between prediabetes and mortality, and prediabetes and major adverse clinical events, which is our point of discussion on prediabetes today. Prediabetes has been found to increase the risk of major clinical events and death independent of the subsequent of diabetes and metabolic factors. The risk relationships between prediabetes and clinical events are stronger in young than in older people. So what are the associated comorbidities and high risk individuals? Insulin resistance, as you all know, is a strong predictor of not only type 2 diabetes but prediabetes as a whole. That hypertension, visceral obesity, glucose intolerance, dyslipidemia, endothelial dysfunction, hyperinsulinemia, all are factors which are strong predictors of prediabetes. And the clinical risks are not treating prediabetes is huge, because like diabetes, ultimately when they develop diabetes, that leads to microvascular and macrovascular complications, as we all know. So the spectrum of the cardiometabolic disease is quite similar. The genetic determinants, the obesity, insulin resistance, all leads to the pre-diabetes stage, and particularly in metabolic syndrome patients. And this leads to not only type 2 diabetes, but also the associated cardiovascular diseases. As we all know, there are certain criteria as per ADA 2022, the latest guidelines, the criteria for screening for diabetes or pre-diabetes in asymptomatic adults. There are certain criteria, particularly in patients with obesity with these risk factors. I'm not going into the details, it's a huge list, like with this dyslipidemia, hypertension, PCO, physical inactivity. Similarly, patients with pre-diabetes, impaired glucose tolerance, impaired fasting glucose should be tested annually. And patients who had been diagnosed with gestational diabetes should have lifelong testing at least every 3 years. For all other patients, testing should begin at 35 years of age, and in other conditions like patients with HIV, they need to be tested for diabetes or pre-diabetes. Dyslipidemia is very important. An association of lipid profiles with insulin resistance and beta cell function in adults with normal glucose tolerance and different categories of impaired glucose regulation is quite important. And it has been found that dyslipidemia might diminish the compensatory insulin secretion to insulin resistance in subjects with IFG and IgT. And high LDL cholesterol is associated with increased probability of pre-diabetes too. Similarly, for hypertension also, the blood glucose levels within a pre-diabetic range is significantly elevated risk of diabetes mellitus. Similarly, when pre-diabetes is concurrent with other disorders such as hypertension, it increases the cardiovascular disease risk. So the cardiovascular risk and pre-diabetes has been shown there can be around 13% increase in all-cause mortality and 13% increase in cardiovascular disease, 10% of peripheral vascular disease, and 6% of strokes. So it's quite a risky thing that if we don't take care of pre-diabetes. So and another point is vitamin D. The physiologic mechanisms of vitamin D involvement in glucose homeostasis includes insulin secretion, its action on systemic inflammation, and also on genetic predisposition to diabetes. Vitamin D, as you all know, it facilitates insulin secretion and action. The pancreatic islet cells contains all components of the vitamin D endocrine system, including the vitamin D receptor, 1-alpha hydroxylase, vitamin D binding protein and all. thereby enabling not only the action of 1-alpha efficiency but also conversion of 25-hydroxy vitamin D into its active forms in the beta cells. So vitamin D supplementation in overweight, obese Asian Indians is quite important, and there are certain studies which have shown that that is quite needed. So regarding the last part of my talk is on management of prediabetes. As you all know, we have to take care of the risk factors like cessation of smoking, caring the treatment for hypertension, adequate control of the lipids. But prevention is very important because, as I said earlier, that we need to lower the risk of microvascular and macrovascular complications. And we should promote prediabetes to revert to normoglycemia. That is our aim for treatment. So what are the strategies? As usual, diet, exercise, other tips, but very importantly, preventive medications are there, and I am going to discuss that in my next few slides. So there are non-pharmacological management and also pharmacological management for diabetes. So there are certain things I will discuss, particularly we will be focusing on metformin therapy, which has been recommended for prevention of type 2 diabetes in adults with prediabetes as typified by the Diabetes Prevention Program, especially for those aged more than 25 years till 60 years, a BMI of more than or equal to 35, higher fasting plasma glucose and higher ANC, and women with prior gestational diabetes. So these are the more risky categories where we can prescribe metformin if the need arises. Several healthy diets are also seen, and Mediterranean diet, DASH diet, all have shown to have decreased the risk of future development of diabetes in certain percentage of patients where they were adequately prescribed by us clinicians. Weight loss goal is very important. Around 5 to 10% initial body weight can reduce 3-year incidence of diabetes by around 60%. So weight loss, whether it's by lifestyle modification like exercise or by diet, and at least 30 minutes of moderate physical activity is quite important. And the recommendations also include diet. We have to try to lose 5 to 10% by maintaining ideal body weight. We have to try to avoid trans fats, food grains which are refined, juices, saturated fats and simple sugars. We have to try to add fibers into it, and very importantly, we have to individualize the percent of calories from fat and carbohydrate based on clinical goals on individualized basis. So dietitian's role is very important. There are certain recommendations of high protein diet which promotes initial weight loss and prevents weight regain also. And there are certain studies which said high protein diet followed for 6 months resulted in 100% reversal to normoglycemia in people with prediabetes compared to 33% in control. Regarding pharmacological intervention, it depends on the self-perception of severity, poor adherence to lifestyle changes as mentioned. Various pharmacological agents have been tried, like not only metformin, alpha-glucosidase inhibitors like acarbose, voglibose, liraglutide, orlistat and insulin. Like metformin in prediabetes is the drug of choice, and it has also been used to prevent or at least delay the onset of diabetes in those who have a higher risk of developing diabetes. There are certain studies like the age-old study of 1996, the Big Pro study, which said that the combination approach of lifestyle modification along with metformin might cause significant weight loss, and it decreases the fasting plasma glucose, plasma insulin concentration also. The landmark trials came up from 1996 to 1999, the Diabetes Prevention Program, and those incidence of diabetes was also seen. And similarly, metformin has been studied in an Indian trial also. Sorry, in the first one I should mention, sorry. The Diabetes Prevention Program of 1996 to 1999, it was a very important trial, and the use of metformin resulted in 31% relative risk reduction in the incidence of type 2 diabetes in IGT during a median follow-up period of around 3 years. Similarly, the Indian Diabetes Prevention Program done by Dr. A. Ramchandran from Chennai and his team, it showed that the cumulative incidence of diabetes in the metformin group was around 40.5% compared to 55% in the control group. And absolute and relative risk reduction with metformin was to the tune of 26.4%. And very important, it showed that metformin used at a very low dose was equally effective to lifestyle modification to prevent diabetes in Asian Indians at high risk. And there was no additional benefit of combining both of them if lifestyle modification fails we can add metformin alone also. There are other studies also with similar results. I am skipping few things, but very importantly, the risk reduction with the usage of metformin has been proved in these studies. So in Indian scenario, the Indian Diabetes Prevention Program showed that lifestyle modification and metformin prevents the type 2 diabetes in Asian Indian subjects, particularly with those with impaired glucose tolerance. And a low dose of even 500 mg once a day was equally effective as lifestyle modification. Then the guidelines are now coming up, like the ADA 2022, which has recommended metformin therapy, and the ICMR guidelines for management of type 2 diabetes in 2018 also said that lifestyle alone is not sufficient, and especially in those with combined IFG and IGT, where progression to type 2 diabetes is quite imminent, use of metformin is very important, and it prevents the progression, rapidly progressing diabetes from the pre-diabetes stage. So the criteria are now quite clear, particularly those with pre-diabetes with obesity, age less than 60 years, and history of gestational diabetes have the strongest evidence that metformin might be used. There are RSSDI ESI clinical practice recommendations also. Even it recommends that addition of metformin 500 mg twice daily after 6 months follow-up is recommended. Alternatively, even alpha-glucosidase inhibitors like acarbose or voglibose can be used in those who are intolerant to metformin as per RSSDI ESI guidelines 2020. So what do other guidelines recommended? Like Canadian Diabetes Association says that metformin may reduce the risk of type 2 diabetes with IGT. Similarly, the IDF says around 250 to 850 mg per day, where lifestyle modification is ineffective in reducing body weight, has helped in these particular patients. So metformin is the first oral treatment to be approved in India for use in pre-diabetes. That is my point today regarding treatment. There are other medications which are now being tried, which particularly decreases body weight, but metformin is the drug of choice. So regarding this, to conclude, India has earned the dubious distinction of being among the top 3 countries with maximum number of diabetics. Similarly, pre-diabetes population is much higher than diabetes in India, adding to the alarming scenario. The primary drivers of the diabetic epidemic is the genetic predisposition with high insulin resistance, fueled by changes in dietary pattern, decrease in physical activity. The considerable comorbid conditions associated with pre-diabetes may often go unrecognized if we are not clinically vigilant regarding those to pick up early. So pre-diabetes is also linked to the retinopathy, neuropathy and nephropathy, as I mentioned. So priority should be given to pharmacological treatment in individuals who are at high risk. So it is of significant importance to screen and identify those at risk, and broad evidence based from clinical trials and previous clinical experience support the efficacy and safety profiles of metformin for diabetes prevention. Among the interventions, metformin has emerged as the most reliable option immediately following lifestyle modification. Thank you for your patient hearing, and I conclude my talk here.
Thank you, Dr. Shankar.
Thank you, sir.
You have given a nice deliberation.
This is the part of the public health leader. The public health leader plays an important role, because the clinician, as a clinician, we are seeing hundreds of patients. They don't have time to teach all the patients that what are the factors which can prevent the diabetes, or in the masses cannot go and teach them. So the role of the public health specialist comes here. So this is my advice to you. And the second thing is, any questions from my postgraduates?
I think such a wonderful presentation, and everything was so convincing. Questions may not be there.
But sir, I need your comments.
One thing is very much important, what I would like to have, and in fact got the significance from this talk, as well as it has already been established by multiple other papers and publication that it is not the diabetes that we should treat now. Our focus of treatment should be the insulin resistance. And insulin resistance should be treated since from the very beginning. Most of the time it happens that patient develops diabetes 2 years after and 2 years, 3-4 years before he gets the heart attack, and that heart attack is because of that diabetes which is yet to come. So diabetes which is yet to come, how can we get rid of the complications of that? The only lifestyle modification is the answer of that, and this should be started from the very early age of our kids, especially all those who are having the first degree relatives of the diabetes, as well as I think every person of the Indian subcontinent is having that inclination for development of the diabetes. And we should learn our all children to start those lifestyle modification, what he is saying, to do in the pre-diabetes. We should consider all of us as a pre-diabetes minus giving the metformin. Without giving the metformin, rest of the things should be instituted in all the population, considering them that more vulnerable to develop diabetes as a pre-diabetes.
Thank you, sir. Useful insights.
I have a question.
I think, sir, we can move ahead with the talks, and then we can add on the spices outside the hall. With due respect to all, may I request our next speaker, Dr. Harish Dalra, who has come all the way from Mysore to deliver his lecture on the treatment of choices in obese type 2 diabetes mellitus. Dr. Harish Dalra. May I have his introductory slide, please? I think, Dr. Dalra, you can move ahead with your presentation.
So, good afternoon, everybody. I am Dr. Harish Dalra from Mysore, and I would like to thank RSSDI BIHAR chapter for inviting me as a speaker. Now, we have heard a lot about obesity and type 2 diabetes, like Dr. Anuj Maheshwari also told us, treat insulin resistance, and one of the important thing is obesity. We have seen a lot of man-made disaster or natural disaster, and I would call this as a medical disaster of a combination of diabetes and obesity. So we have to have this double trouble, and we have to look beyond medication. I'm sure a lot of people have spoken about GLP-1 analogs, SGLT2 inhibitors. So is there anything else we could do to move forward with this obesity and diabetes? So the agenda of today's talk would be is obesity and prevalence, then look at obesity-related diseases, effect of weight loss or diabetic patient, and how are we going to manage, lifestyle modification, as everybody's been emphasizing, physical activity, diet, medical management, which I'm going to talk very less about it, and surgical management. So day in and day out, we just see in newspapers and a lot of articles about obesity and India. So that's not a good news for us. Then we are the second largest obese children whom we have in India, and almost it is growing at a very rapid rate. And if you look at this article, which says that there was hardly about 4 to 6 bariatric surgery which was done in 2001 and has increased to 30,000 in 2016. That just shows that the enormity of obesity in diabetic patient, and where we need to look beyond medication to get it controlled. And this will definitely give us an eye-opener. This is a chart, this is a map which in 1990 which shows what was the overweight in adult patients. And this in 26 years, if you could see that everything is changed. And luckily where we are standing today, Bihar, and where I come from, Karnataka, though it is increased from less than 9% to 19%, but if you see there's the enormity of obesity and overweight which is increased in India in the last 26 years. So globally we have 1.9 billion people who are overweight and about 650 million who are obese. And we all know that 1 in 6 person who has a mortality or morbidity is because of overweight, obesity, hypertension and diabetes. And India is a population with 13.5 crore who is overweight and obese. So that has a lot of enormity with what diabetes can add on to with obesity. So this is an ICMR data which shows that obesity is about 11.8 to 31%, central obesity between 16 to 36%. And we all look at from what we have seen the diagnosis we are metabolically obese because of central obesity. There's a lot of inflammatory markers which I don't need to elaborate. This is the reason for insulin resistance. So 2016, the WHO had shown that there was an increase of about 3.4% of prevalence of overweight in India from 2006 to 2016. And there is about 1 million deaths in India because of diabetes, and it's a leading cause for blindness, kidney failure, heart attacks and stroke and lower limb amputation in India. So we know that there is a lot of prevalence of generalized obesity, abdominal obesity and combined obesity in type 2 diabetic patient in India, and you can look at the percentages as well. More than 90% of our diabetic patients are overweight. So this excess fat is mostly in the viscera, which can be, or excuse me, central obesity, which can easily be calculated by clinically as waist-hip ratio we can do, which is easily, we can see that. And weight loss improves all the parameters and also improves insulin resistance. So we have a waist circumference which has been mandated for Asian population for men of less than 85 and waist-hip ratio of less than 0.9, and women of waist circumference of less than 80 and a waist-hip ratio of less than 0.8. And again, there is a definitive Asian population BMI which is based here, which are just and it's completely different from the Caucasian population. So when we manage obesity in type 2 diabetic patient, all the clinicians should be very sensitive when we discuss about obesity. We have to empathize. We can't, the way a lean person is treated rather than obese person is completely different because of the mindset of the clinician. So we should not be biased towards an obese diabetic patient, be more sensitive to them, and lack of time and training is one of the most important part where we disengage from discussing about obesity. So these are 5 A's which we have to see in a patient with obesity. You have to assess if this patient who is obese has metabolic risk factors or not. You assess whether the patient is ready to take your decision to lose weight. You advise them what are the complications which can happen because of obesity, and also you advise that if you start losing weight, then the chances of having complications are much lesser. You have to come on an agreeable term of what is the weight loss we need. We have to be very realistic. We can't have a judgmental that you have to lose about 20 kgs. Take it slowly, but take it and further up. You have to assist the patient, either get them to a good dietitian, you see what exercise program they can do and arrange for a follow-up on a regular basis. So we are going to see in patients with intensive behavioral counseling, obesity pharmacotherapy and bariatric surgery. So where do we start? What treatment? Lifestyle modification, intensive life therapy with all diabetic patients. Pharmacotherapy, yes, definitely with GLP-1 and SGLT2 inhibitor. It can be with all the BMI, whatever is there. But definitely metabolic obesity has to be looked at an BMI of more than 30 or more than 27 in an Asian patient. So what are the exercises? I'm sure the last speaker did elucidate about either 30 or 60 minutes of daily walking is very important in all diabetic patients, or if it is 150 minutes of rigorous exercise at least 3 days a week and not more than 2 days being left over. So that is very important exercise which will help with weight loss and managing diabetes. And again, you have to have a 3 sessions of a week for resistance training is very important. So prolonged sitting has to be avoided. Every 30 minutes somebody has to get up and walk for a minute or two to break the cycle of obesity. And this is again a very nice chart given in ADA where there is 5 S's. Sitting, break the sitting for every 30 minutes or 1 or 2 minutes. Stepping at least increase by 500 steps if you can walk. It reduces the incidence of cardiac disease by 2 to 9%, and every 5 to 6 minutes of brisk walking in a day can prolong the life of an individual by 4 years. Sleep, get a good sleep for more than 8 hours. Again, I have told you about moderate exercise which is required, and strengthening exercise is mandatory. So lifestyle modification, when you come to diet, very important part is, yes, you have to have a realistic goal of about 5 to 10% of weight loss is recommended, which does reduce the A1C by 0.6 to 1%. And 25% reduction in mortality is seen in a diabetic patient who's lost about 8 to 10 kgs and can be on remission in an early diabetic stage if they lose about 8 kgs for about 2 years from the day of onset of their diabetes or diagnosis of their diabetes. there are various weight loss programs which are done, and even in India you have various weight loss programs which helps in losing weight, but they only concentrate on weight because they are non-medical people who look more into weight loss. So lifestyle changes are effective, however they are notoriously difficult to achieve and maintain it on the longer run. Yes, initially we all dietitian, they give a carb deficit of about 500 to 750 kilocalories. Reducing calories is effective in achieving weight loss along with exercise is very important. So what are the different dietary patterns which are now looked at is intermittent fasting. I'm sure a lot of patients do come and ask about whether they can do intermittent fasting or not in a diabetic patient. This is gaining quite a lot of popularity in chronic diseases such as diabetes. And intermittent fasting, the principle is having either low calorie or no calorie diet on a regular basis in a regular pattern. Medical guidelines regarding intermittent diabetes and diabetes is not many. There are few papers which have been presented, but there is no robust data regarding intermittent fasting in diabetic patients. So there is a metabolic switch in intermittent fasting from glucose-centric. We are looking at free fatty acid or ketones, which is used as an energy utilization. So there are a lot of diet patterns which are seen as a time-restricted diet where a patient will fast for about 16 to 18 hours and eat intermittently between 6 to 8 hours in a day, and that is basically in the morning hours from 6 to 12 o'clock is what they eat, and the rest of the days they fast. Now this is very difficult to achieve in a diabetic patient who is on a lot of medications such as insulin, sulfonylureas, other things. They can have hypoglycemia, and there are other things such as alternate day fasting. When I say alternate days fasting, one day they eat normally as a diabetic patient, the next day they eat only 25% of what is the kilocalories they require. So that is basically not complete fasting but reduced calorie. Then there is 5:2 diet, is they eat for 5 days and 2 days they are on a diet, or they are on a restricted calories, which is on non-consecutive days. So there are various patterns of intermittent fasting which is used. So just looking into a few publications in diabetes and non-diabetic, this alternate days fasting is seen. So if you look at a lot of parameters in non-diabetic patient also, if you look at the weight gain, we know that there is increased leptin in a diabetic patient with insulin resistance and decreased adiponectin. In most of the studies, they have seen that there is a good weight loss with alternate days fasting. There is reduced in leptin level and increased adiponectin level is also seen. Then you see in time restricted diet where they fast for about 16 to 18 hours in a day. Again, if you look at various parameters of their weight, blood glucose level, A1C level, adiponectin and leptin, there is an improvement in patients who have fasted on a time restricted diet. Now this is alternate days diet where I had told you that one day they eat normally as a diabetic patient, the other day they have only 25% of their calories required per day. Again, there is a good improvement in weight, anywhere between 3 kgs to 10 kgs they lose weight, and there is a good improvement in A1C from 0.8% to about 4% reduction in HbA1c. And keto diet again is gaining a lot of popularity, not used in patients who are on SGLT2 inhibitors, and again in type 1 diabetic it is contraindicated. So they take a lot of fat, restricted calories. Again, they have shown that there is a lot of HbA1c reduction is there, weight loss is there, and there is improvement in lipid parameters. So pharmacotherapy, again, yes, we have to choose a molecule which will at least reduce their weight. Be cautious about using molecules such as sulfonylureas or insulin in an obese patient. So we have to look at alternative therapy if a patient is not losing less than 5% of their weight on pharmacotherapy. So we know that insulin, sulfonylureas and thiazolidines do increase weight gain, and this is a study which showed that GLP-1 analogs or SGLT2 inhibitors is how much percentage can a person lose. So all these studies have shown that there can be a weight loss about 2% to about 7.5% on various SGLT2 or GLP-1 analogs. This is a randomized control trial where they have looked at GLP-1 versus SGLT2 inhibitors. Again, they have compared canagliflozin when they looked at all the other SGLT2 or a GLP-1 analog. You could see that semaglutide with 2.4 milligrams had a major weight loss of about around 13 kgs, and they persisted with more than 5% weight loss in about 15% of these patients who were on a semaglutide. So you look at dapagliflozin, empagliflozin, again if you look at semaglutide of 2.4 milligrams, they achieved the most weight loss and also maintained weight for a longer duration of time. Again exenatide, dulaglutide, liraglutide, but the best one was of semaglutide, which SGLT2 or GLP-1 analog you use. There is a good weight loss and people maintain that weight for a longer duration of time. Again, there are other medications such as orlistat, not much used because of a lot of side effects. Lorcaserin, topiramate has been used. So these are certain other medications which can be looked at. But most important is metabolic surgery. Now this is catching up quite well in diabetic obese patients. So what is metabolic surgery is it's recommended in all type 2 diabetic patients who are more than BMI of more than 40 kg per meter square, or somebody who's tried out all the medication with lifestyle modification. If they are not losing weight and have other comorbidities, they can be a candidate for metabolic surgeries. People who are evaluated for comorbidities, as I told you, is prior to metabolic surgery, please evaluate them for their psychological issues, if they could maintain that post-surgery, because there's a lot of things which they have to do post-surgery. So pre and post-surgery psychological evaluation is very, very important for patients who are undergoing metabolic surgery. So the commonest metabolic surgery, as we all know, is vertical sleeve gastrectomy or Roxanne surgery. In vertical sleeve gastrectomy, 80% of the stomach is removed and it becomes a tubular structure where they could not eat more. So the quantity of food taken is very less. But in Roxanne, again, they just make like a small walnut structure which is there, and the jejunum is connected to the upper part of stomach, and the duodenum is connected to the proximal distal jejunum. So the gastric juices are there in the jejunum for digestion. So they can't, the pouch is only about 30 to 60 ml pouch is what is left behind. So they eat very small proportion of food on a regular basis is very important. And people who have undergone this bariatric surgery are in remission for at least 8 years post-surgery. So their diabetes, hypertension, dyslipidemia, everything improves in patients who have undergone this metabolic surgery. So there are other weight loss devices. I'm sure a lot of things are not done here, but there is nothing wrong in knowing what these are. This is a gastric band, which is FDA approved, and what they do is they put this gastric band around the upper part of the stomach, and it makes as a small pouch. Now if you see the other side, on your right hand side, there's an access port which is just beneath the skin. So they can inject or release the amount of saline what is used to either inflate or deflate the band around the stomach to improve the opening, so that it becomes a small pouch, so they can eat very small proportion. And people who have done this have lost about 15 to 20% of their weight and have become even in remission in diabetic patient. So this is gastric balloons which is available and even in India it's being done as there is Orbera gastric balloon where they fill in. It's an endoscopic procedure which is to be done on a sedation. So they put in the balloon, they inflate it with saline, about 750 ml of saline. It's basically a space occupying the object in the stomach which reduces the food intake. Again, this is recommended for 30 to 40 of BMI, and this is a reversible procedure and has to be removed in 6 months time. People again have lost weight on this procedure. So this is a Spatz adjustable balloon. The one previously one is not an adjustable one because it just takes a quantified amount of saline to be in 750 ml. But this is an adjustable balloon. It can be increased or reduced. The saline can be increased or reduced on an endoscopic procedure. Again, this has a life of about 8 months and has to be removed after 8 months. And this is an Obalon balloon system where this is a small capsule which is ingested in an OPD procedure and found out if it is in the right place on an X-ray X-ray one, and then 3 balloons can be ingested over a period of time. Not that they have done on the same day, but it is done after a week. And each balloon is inflated with. I'll just take 2 minutes. Each balloon is inflated with about 250 ml of saline and can be left in place for about 6 months. Again, this either insertion or to be removed is on an endoscopic procedure. This is very, very freely available in US where it is done as an outpatient procedure, but it costs quite a lot. And this is another device which is transpyloric shuttle delivery, again to be delivered under anesthesia on an endoscopic procedure. Now if you see, there is 2 things there. One is a larger balloon and one is a small balloon. So either it can, all things can be left in the stomach itself, or the larger balloon can be at the gastroduodenal junction and the smaller balloon can be in the duodenum. Now this acts again as a space occupying lesion and prevents the gastric emptying, or rather delays the gastric emptying by having it in the duodenal junction. You have other sensory monitored elementary restriction diet, such as a pellet, heart pellet sense device, where they take a measurement and put a small device on the heart pellet, which reduces the amount of food what is taken, or the bite size is reduced. So they have to chew for a long time and they take very small amount, and this can be monitored if the patient is using or not with a smart reader. Again, this is being used but not very successful in losing weight. And this is again a small capsule called Plenity, which is available in market in US, where a patient takes 3 capsules prior to his or her meal. They take it with water, and they absorb water and forms a space occupying lesion in the stomach, where they reduced food intake, and then the water gets reabsorbed and it is digested. Again, it is pretty expensive and has to be taken with all the meals. And these are duodenal jejunal bypass liner, which is about 60 centimeters, and they put it from the duodenum to the jejunum. Again, it prevents the contact of food with the duodenal and jejunal liner, so that they pass through into the jejunum, and there is an increased GLP-1 and GIP-1 within a few minutes after food intake. Now again, this is being stopped because there was a lot of incidence of liver abscess during the procedure and post-procedure. You have a little longer one, is gastroduodenal jejunal bypass. Yeah. So this is about 120 centimeters. Again, the problem was liver abscess. It has been discontinued. And this is another procedure where, I'll just show you the slide, is they have to use bidirectional, one is an endoscopy and a colonoscopy, where they have a small magnet. A magnet is placed at the proximal end of jejunum, and the other one through the colonoscopy is placed at the ileum. And when they both come in contact, they form a necrosis of that and forms an anastomosis. So this is basically you are creating an anastomosis with magnets, and again the food from the jejunum passes into the ileum quite quickly. So this is my last slide. Is it's always prevention is better than cure. So you have to start young with education, either be in school or college. Target the risk audiences immediately, family members. Community and continuing education is very, very important. Obesity is a very sensitive issue. Tackle with care. Don't be judgmental. Empathize with your patient. Treat the patient disease and comorbidities, not glucose-centric approach. Set a realistic goal and time duration and achieve your patients to get it. Emphasize on lifestyle modification. There is no shortcut for a good diet and exercise. Pharmacotherapy should be chosen based on the patient profile and comorbidities. Consider surgical procedure if the interventions are not achieving the goal what you need for weight loss. Thank you.
Thank you, Dr. Harish. Excellent deliberation on the obesity. I was just thinking that whether the sumos of the China, they were diabetic or not with the obesity, because they were obese also. So I don't know whether they were.
Sumo wrestler of Japan. Sumo wrestler.
I'm not sure, but I don't think so. They're diabetic, I suppose.
Yeah. And the second thing is that it is really the liposuction which the recently has gone along there. Is it effective in treating obesity?
I don't think so, sir. Liposuction is a good choice for obesity because it's a very temporary procedure. So somebody who needs to look good in the next few months or days, is they undergo liposuction. But yes, you remove the fat, but if the lifestyle modification is not changed, it is going to come back. And it's not that it is without any side effects. There have been instances of fat embolism and death because of liposuction. So that's a very temporary procedure and not a long-term procedure.
Any data you have regarding the surgeries which we do to reduce the obesity?
Any data regarding surgery?
Yeah.
Yes,
Metabolic surgery.
yes, vertical sleeve gastrectomy and Roxanne is very commonly done surgery even in India for bariatric as a bariatric procedure, sir.
And it is effective.
It is definitely effective. At least I have got 5 patients of mine who have undergone bariatric surgery and they are in diabetic remission for the last 8 to 10 years. The longest one is about 10 years who's been on remission. There is a couple of patients who have gone on a small dose of metformin at this point in time, but majority are on remission.
Thank you. Any questions from the house? So,
Thank you.
Hello. Both the speakers have done very well, no doubt. It is a message from this dash. We, every doctor, must move to the village and adopt the pre-diabetic and do the glucose level of the populations, because every person above 30 years are likely to be diabetic in few years. So our goal is to reduce the incidence of the diabetes. So we have to move for this purpose. Thank you.
Thank you so much, chairperson and speaker. And it is a pre-lunch session and everybody is getting restless. So may we ask chairpersons to honor our first speaker, Dr. Shankha Sen, who's come all the way from Siliguri to. And now may I request our chairpersons to please honor Dr. Harish from Mysore with a memento and a bouquet. Thank you so much, sir, for taking out time from his busy schedule. And he was actually supposed to arrive tomorrow, but it is our good luck that he has come today. And I'll request our speakers to please honor the chairpersons with bouquet. Shawl, a big hand for our chairpersons and speakers, please. Thank you so much, sir. And we will take a short break now for lunch, and we will reassemble here after half an hour. Thank you so much. Ashok Kumar, sir. Akash Singh, sir. Akash Singh, sir. Ashok Singh is not here. Yeah. And they will introduce the speakers for the next session.
A very good afternoon, dear friends, ladies and gentlemen. It's my pleasure to invite Dr. Subhash Kumar, Secretary of Bihar Chapter RSSDI, and he is going to talk on upstream approach in the management of diabetes with oral semaglutide. Without further ado, I will request Subhash to start his lecture.
Respected Ajay sir and persons of the dais and dignitaries of this conference, it is an honor to be here, especially when Ajay sir is sitting, our teacher and pride of Bihar. Not only Bihar, he has represented us across the world. So we have many bad names, but then when we look at sir, we feel proud that we have some icon who we can always vouch for, and we are recognized because of him in several occasions. And this talk is a kind of a replacement talk for me, but then it is nice to discuss an upstream approach in the management of diabetes, particularly when we have a newer class of drug, that is oral GLP-1 analog. And these are wonderful drugs, and I am very happy to present this talk because I have used it in many of my people who are living with diabetes, those who are obese particularly. And we understand that the burden we have to look after people in our country is much worse than across the world. Maybe we have the highest number, it is called second, but we do have to look at altogether a different pathophysiological defect which start with obesity and related problem. So addressing this problem, we have been earlier we had a prevention, maybe a secondary and primary, and we think of preventing disease at the time when it has already crossed the head. And today itself, Ajay sir was just stimulating me to say that why don't we do a study to find out what type of people come to us at the onset of the disease, and how is his level of insulin and his other factors associated. And it is really important to understand the defect which we are dealing is something not as same as across the world, or you can say non-Asian in comparison. And I am going to discuss a little different aspect of the treatment of diabetes in that regard. We understand obesity is becoming, as Dr. Harish, his previous talk from Mysore, he talked that we have the highest number of kids developing obesity, which is really an issue of concern, and we all should be focusing on it, that our kids are becoming more obese than in comparison to other world. And this has to do with our lifestyle and genetic factors. And this is the starting point. And when we talk about upstream management, it is not that when we diagnose and we start teaching them that how to change their life and what is the importance of weight. It is even before we should be addressing it, because it has been proved in a number of trials, and some of the very seminal trials have proved that we are thin fat Indian, and Dr. Yagnik and his team has clearly given us the importance of having a bad visceral obesity comparison to all other part of world. And this is why our people have obesity. Our people have more of obesity before we start detecting them as a diabetic. So we should be targeting this issue of thin fat Indian, and our BMI is also lesser because of the same reason. So we have an environment now, though we have economic development has changed our food habit, and thanks to our Prime Minister going back to all those old pattern of having a meal which is very good on millets, but then we have Zomato and Swiggy, which is going to affect the food habit of our current generation, and as well as all other people around. And physical activity has gone down, which we all understand. I'm not going to discuss in that much in great regard, but we all together have an issue which is very much helpful in terms of developing adiposity, and ultimately which is going to lead to the all those core defects of diabetes. And this is what we have to address even before we can diagnose them as diabetes, or at least the earliest possible time when we can see the defect is coming, it is something to do with adiposity, and we do understand the reason behind it, associated with hyperinsulinism and insulin resistance, all those factors associated with other related day-to-day living. So complication due to increased body weight, I think I don't need to discuss, but then we also have not only the cardiovascular risk, we should focus on non-cardiovascular risk, and we hardly see people with obesity are depressed, and we are addressing them adequately, and we are looking at them, and hyperglycemia, hypertriglyceridemia. I think all these factors which we see, the non-cardiovascular and cardiovascular defect, are very pertinent to obesity, and all this are interlinked. And if we can target somewhere on that defect, we can help them in a bigger way, and that too at very early stage of the disease, which could prevent all those cardiovascular and non-cardiovascular risks. And this is how this upstream approach is. The talk all about that if we address adiposity or obesity earlier, we can prevent all those downstream problems like associated, which I was just talking about, the obstructive, starting from obstructive sleep apnea to non-alcoholic fatty liver disease, osteoarthritis, hyperlipidemia, and which is ultimately we have the diabetes and coronary heart disease and all, and furthermore related to macrovascular complications. So we do have answer to this, and we can always work at in our people once they have a little whim of developing adiposity, and they have a weight related issue, and we should look at the benefit and how to cut down the disease, the progress of disease. We know that weight loss can be of benefit. There are a number of trials again, and we can always, in early days of diabetes development, if we can cut down the weight, we can certainly do a kind of reversal, or we can also bring down at least the speed of disease. And for that, look ahead trial has given a clear insight that even a 7% weight loss can be of great benefit in terms of pre-diabetic people becoming a non-diabetic, or at least the A1C reduction is much pronounced in such with the weight loss. So weight loss has immense benefit. The problem is that it is difficult to achieve, and we have a number of approaches which is there, but we may not be able to achieve the target, and we need to have lifestyle and diet and behavior therapy. Today I conducted a workshop for the postgraduate, and it went very well when they are really sensitized to how to bring about the behavior modification in people, in our patients, when they want to have their dietary habit change, when they want to have their smoking habit change, or when they want to bring about their insulin or diabetes or therapy. So these things we did discuss, and it was very satisfying that they were very happy with the whole thing. And then we also should learn about the other factors related to physical activity and patient support system, which we hardly have, and which this Bhagalpur conference will help people after having this conference to build up a patient support team. And then we have a pharmacotherapy. We have several other drugs which are not in any more practice due to several reasons, but still we have orlistat, and then we have liraglutide, semaglutide, and we have naltrexone, bupropion, and phentermine and topiramate, which is again not practiced, but we do have orlistat, liraglutide, and semaglutide as a pharmacotherapy. And then weight loss surgery is also very, very important and very effective with the BMI of more than 30, where people with diabetes, they go for remission. I think we had a very elaborate talk by Dr. Haris that what all different types of surgeries and we can have procedures which can help them. So let us talk about unmet need of therapy. Weight loss becomes a very big problem because to sustain the weight loss is a problem. any early weight loss of say 2 to 5 kg will come in with little ease, but then afterwards the body has its own hormonal mechanism where it recognizes that whatever adiposity is there in body in history, and it tries to regain. And this is the bigger issue when we are treating patient with obesity, that after some time they don't either maintain or they regain the weight. It is because of the neurohormones which play in a role where they have a set point memory and they try to regain whatever the fat loss has happened. And in that case, we need to intervene in these conditions with different pharmacotherapy, because just by diet and behavior modification will not be sufficient to either maintain or to further reduce the weight. So we have to have a multi-pronged approach to have this unmet need of weight loss, and the molecule which can address this are GLP-1 receptor agonist, and I'm very sure that these are the molecule which is one of them have right now semaglutide oral drug and then injectable liraglutide, and many more are in pipeline, and there are again combinations. So this is going to change the history of obesity in those who are practicing, because these are wonderful drug, and the thing that the point which we miss in our practice, that we are not able to offer anything to people with obesity, and the drugs can help them in much bigger way, and they do have all advantages which I'm not going to again reiterate in terms of reducing the blood glucose, having no hypoglycemia, and approved for approved for different indication, including all those comorbid conditions. It does help cardiovascular health and other issues. So if you look at, I was just talking about the neurohormonal mechanism of weight loss. These GLP-1 receptor analogs, they work at the arcuate nucleus on the higher side, and they have an inhibitory effect on parabronchial nucleus, where they directly stimulate the APPB projection, which ultimately brings down the satiety, which improves the satiety portion, and the feeling or desire to eat further becomes less. So a person can be more satisfied, and this is the hormone which this is the place which used to stimulate people to eat more once they lose weight. After having a loss of say 5 to 6 kgs, a person will not be able to resist his desire to maintain the diet, the calorie, and these hormones, they interplay, as well as they bring down the basal metabolic rate. So even with the less calorie intake, you are not burning anymore with a normal physical activity, which used to be more higher when you were obese. So this is the mechanism by which your body resists further losing the adipocytes, and this is the place, with the help of semaglutide, we can intervene and we can further train our brain to have less appetite and more satisfied with the whatever calorie which they are trying to get. So there is a direct activation at the level of hypothalamus and hindbrain. So what it brings out? It brings out the weight loss, almost the tune of 2.6 to more than that, and it is a fat loss. It is not the lean mass, because if you look at the rounded red area, the lean mass is very less in comparison to the fat mass, and this is a very welcome point, because we are getting rid all those unwanted adipocytes, and then A1C control is much better. We have almost 8 out of 10 people achieving the target of less than 7 with the use of oral semaglutide in Pioneer 1. I think this has been discussed in many of the trials, but these are one of the trials which has changed the thinking of oral therapy, and this has been also included in all the guidelines. And weight loss of almost equal or less than 5% of what is achieved. Pioneer 8, if you look at week 26 and 52, again the duration is also very important, and you have a weight loss of more than 5%. The point is the weight loss is maintained. So we have the issue when we used to regain with the help of this molecule, we are able to sustain the weight loss for longer duration. I think the same point Dr. Harish was also talking, that these are the drugs which can help. And then change in body weight in the treatment, we have different Pioneer 1 to Pioneer 8. They have shown that we can lose weight up to 5 kg in these trials. So weight loss is sustained. Again, further the same, it emphasizes the similar point that it is maintained for longer duration of time. And change from baseline in body weight by background age is again very important, that we have even across the weight age we can have weight loss. So we think that old people or maybe frail people, they may not lose weight, but now we have a option of using this, and this has shown benefit. And I agree with this particular slide, because I have used in some older age people due to other reason, and they did show benefit, though I have to train them a little bit more than the younger people, but in terms of reducing the gastritis and other thing, they do get benefit in weight loss. So we have again change from baseline in weight management. You can see consistent weight loss was regardless of background medication. So across any drug if you're using, there is a weight loss, whichever drug you have used along with this oral semaglutide. And now in terms of HbA1c reduction, I think I have already discussed up to 1.5% of HbA1c reduction, which makes it more than intermediate acting drug, intermediate potent drug. And that's why we have now guideline which is promoting to use GLP-1 receptor agonist. And other than oral injectables ones, also we have seen the benefits which comes in terms of atherosclerotic cardiovascular disease, and then we have a heart failure benefit more with SGLT2, but then these are also drugs which can be added and should be used along with. These are safe, and even in CKD. So we have been a clear recommendation that if you have atherosclerotic cardiovascular disease, GLP-1 receptors are the drug of choice to start with, and we don't have to wait for metformin first, and then we can go straight with the GLP-1 if you can think that they are going to benefit. I think this is the same thing. This gentleman, Pawan, he's having obesity with uncontrolled diabetes on metformin, and we have and we treated with metformin. Ultimately, we are losing control over it, and it progresses to the complication if we have not acted upstream of the management, like we have not acted before the time has lost, and we waited for diet, exercise, metformin to act, and lifestyle modification, and only lifestyle modification and just a previous way of treating diabetes are not going to bring down the risk of atherosclerosis and other things. And in that term, if we add a GLP-1 receptor agonist, we are going to get benefit in not only cardiovascular and all other factors which I just discussed, cardiovascular and non-cardiovascular benefit with weight loss. And we treated Pawan, and you can see after say 3 years, he has A1C of from 8.3 to 6.8 with weight loss, BMI from 31 kg to 28.3 kgs, and weight loss 91 to 78, and you can see all the benefit which we saw. So if we start this drug early, we get more benefit. Even before the patient becomes further obese, even before his HbA1c is lost, we can titrate, we can regulate his whole habit of eating, and his glycemic parameters can be held. So I think I'm not short of time, but then I'll just skip that. We have a newer class of drug to help people with diabetes, and they have some benefit which was not seen, and oral has come with more benefit because injectable ones were really tough to initiate, and we can achieve much better target and much better life for people living with diabetes in our country. Thank you.
Thank you, Dr. Subhash, for your very nice presentation. The topic is open for discussion. If you have any questions or comments, please make. Yes, Dr. Virmani.
Comment. Can I have the mic, please? Mic. See, I think we have, even after so many years, we have still not reached the final destination of how we should treat diabetes. We started with being glucocentric after the UKPDS study. Then came the ICOD and the VAT, and they taught us to be afraid of hypoglycemia, so we became hypoglycemic centric. Then came the Empire study, and we were taught that, look, complications are more important, so we became complication centric. Now, I don't know what has driven us barking up the obesity tree. Is it pharma-induced, or is it the various trials that have recently come out? Now they are telling us, be obesity-centric. But I think the final destination still is being holistic in approach and not being tried to either be glucocentric or complication-centric or obesity-centric. We have seen, even in patients of pre-diabetes, that the DPP study showed you can prevent diabetes. But when the DPPO study was done, which was a continuation of the study, it showed that we cannot prevent the complications. You may prevent diabetes, but you won't prevent the complications. So what is the sense in preventing diabetes? And then we realized that in those patients where we were also controlling the blood pressure, the weight, the lipids, complications are much less. So I think ultimately we have to reach a situation where a holistic approach is more important than trying to be either glucocentric or obesity-centric.
Okay, thank you. Any other comment or question, please? Dr. Santosh. Mike मान लीजिए.
ठीक है, सुनना मेरे. Only addendum to what
was has said, clinical experience, when we see in our patients, I have told you in the past also, in my own series, 80% of the patients, they do lost weight along with glycemic control. But glycemic control only 100%. The people who didn't lose weight, I couldn't gather anything. But the patient who lost the maximum weight, it was very evident in the very first month. And majority of them, I would say almost 100%, were receiving L-thyroxine. So that is a very interesting observation I had. Then tomorrow I will be talking something like this. It's in addendum to again Dr. Anuj's talk on NAFLD. GLP-1 receptor agonists have effect on reducing the thyroid hormone resistance. And nowadays we are striving for resmetirom, which is a TSH receptor beta, which is acting on that. And by this way, this could be an additive drug. Dr. Virmani talked about the holistic approach. These molecules, they are not only for weight loss, as I mentioned, they have their glucose reducing potential in 100%. Now, if you categorize the patients according to the complications, we are well versed with the contribution of visceral adiposity in progression of diabetes and in the diabetic complications thereof. If you can take care of this aspect, you are able to reduce those complications, including development of diabetes. And if you remember the AS guideline of management in type 2, the pharmacotherapy, and if multiple risk factors, it is pioglitazone or GLP-1 receptor agonist. And I think we need to think definitely in a proactive way to use these molecules in those patient populations, knowing well that the conversion from pre-diabetes to diabetes is more in patients who have hepatic fat compared to patients with visceral obesity, which is responsible for the whole management. So these group of molecules are not only for glycemia. If I'll give an example of insulin therapy, when we escalate, intensify insulin, in between comes the addition of GLP-1 receptor agonists. And by that way, they are at par with the basal bolus or basal bolus in having control with the addition advantage of glucose control without hypoglycemia and less of weight gain. So these molecules, they do have a whole spectrum in the management of diabetes.
Thank you. Co-chairperson Dr. Akash, would you like to make any comment?
My observation in semaglutide is that majority of the patients have got stuck up to around 7 milligram dose. There, the glycemic benefits and the weight benefits are not that great as have been proclaimed yesterday. The results may be different from 14 milligram dose, but as of now, majority of the patients are stuck up at 7 milligram. Very few are taking 14 milligram.
I would like to make one comment, and this is more in the form of a question. You briefly mentioned about the appetite-inducing hormones and appetite-suppressing hormones, which are indirectly influenced, directly or indirectly influenced by semaglutide. And we also know that the bariatric surgery also leads to the alteration in those hormones. If that is the case, have we made any progress in actually producing drugs specifically related to those hormones in treatment of obesity?
Any new drugs?
Yeah, like neuropeptide YY or ghrelin or leptin, etc., etc. These are the contrasting hormones. If they are the intermediates, why can't we make drugs particularly targeting them? They would be more effective than indirect molecules like semaglutide.
Yes, sir, very true. And actually, this was they have done trial on leptin infusion, and the result were not promising. So the trial was stopped, which I read. And the reason behind that, we do develop rapid leptin resistance. So at the level of arcuate nucleus, we don't know how it interplays, but the same hormone which we understand is responsible, even in experimental model, it has not shown benefit in terms of weight loss and other cardiovascular endpoints. So
and the other thing is that, is it dose dependent? Because we know that 3 and 7 milligram have a salutary impact in reducing the HbA1c to the desired level. But if we really want to get the weight benefit, you have to go to 14 milligram, and similarly injectable semaglutide, we are talking about 2.4 milligram rather than anti-diabetic dose of semaglutide injectable. So if it is dose dependent, may be that we actually don't understand the complete pathogenetic mechanism through which these molecules act.
Yes, sir, very true. Actually, it is what you, sir, is pointing that it is dose dependent, and we understand the mechanism of GLP-1 GLP receptor or incretin hormone. Otherwise, that it once we have a meal, these hormones sensitizes the beta cell, and it also goes to the higher center to stimulate those neurohormones. And in diabetic people, we have a problem of this incretin hormone deficiency. And if we don't adequately use these GLP-1 receptor agonists, which ultimately which helps in terms of improving the incretin GIP and GLP-1, we are not going to achieve the target. So higher the dose, we get the benefit in terms of weight loss, and right dose is very important. However, it also depends on person to person and the deficiency of incretin. So it is the right thing, as sir mentioned, that it should be dose dependent, and if we use underdose will not get all those benefits which are shown either in terms of glycemic parameter or maybe even weight loss.
Right. With this, we come to the end of this particular session. Thank you, Dr. Subhas. Thank you very much. Who is the next speaker? May I ask from the organizers, because a lot of changes have been made in the program. Supriyo is the next speaker. Okay. So it's my pleasure to invite Dr. Supriyo Mukherjee. Needs no introduction to this audience, and he is going to talk about exercise in type 1 diabetes. Floor is yours.
Thank you, sir. It's a privilege to be here in this August gathering, but chaired by none other than Dr. Ajay Kumar and my friend Dr. Akash, Dr. Anuj Maneshwari, and all friends, ladies and gentlemen. This is a privilege, rather. Thank you for inviting me, the team RSSDI Bhagalpur. My topic, how to move? Yeah. My topic is exercise in type 1 diabetes. To start with, I start with a question. Exercise is important, and type 1 diabetes is basically, we don't understand why don't we prescribe exercise in any diabetes? Why don't we have? Because probably we never thought of that. Or this is a research question. Why don't we prescribe? Why we avoid prescribing diabetes prescription, exercise prescription? If you see that you know them all, I exactly know that you know them all, but what is common in them? This common is type 1 diabetes and their zeal and focus. You know, from historic perspective, there's a regular physical activity has been prescribed for cardiometabolic health since the last 6th century BCE in India. Shushruta, the pioneer, promoted exercise to minimize the consequences of obesity and diabetes. And he very articulately told that to be effective, exercise has to be daily and moderate in intensity and never excessive, or to exceed the half maximum limit for exhaustion, because disease or even death could ensue. This is such a modern, remarkably modern outlook. And irony is that it was told by Charles Dipton to us. We could not. And he put in his historical perspective that Sushruta was remarkably modern, and that future authors of the history of exercise physiology should include contributions from ancient India. Here, type 1 diabetes is a challenging condition to manage for various physiological and behavioral reasons. That is, first, the people with type 1 diabetes tend to be at least as inactive as general population. Most do not have a healthy body weight. 60% are obese and overweight with dyslipidemia, and 40% have hypertension. Most do not engage in regular exercise, and in adults with type 1 diabetes, with retinopathy, microalbuminuria are less common in those who are physically active, and in children who exercise regularly have the improved body composition, cardiorespiratory fitness, endothelial function, and blood lipid profile are improved, and there's a reduced glycemic variability. Hemoglobin A1C is less decreased around 0.3 to 0.5, and there's an improved renal function in those persons who are children and young adults who regularly exercise. And once I wanted to search what is why exercise in type 1 diabetes is important. Then I found, by putting this in Google search, in 0.5 seconds, 36 million results were there. So what I thought that it is really very important. So the most one of the very critical trial, which was done by Vaughan and Pfeiffer, that said that patients who were categorized as being most physically active had a better HbA1c, more favorable BMI, less dyslipidemia, hypertension, and few diabetes-related complications. And patients with type 1 diabetes who are more active tend to have less diabetic ketoacidosis and a reduced risk of developing severe hypoglycemia with coma. And there are many benefits of exercise. There are have a cardiovascular benefits. There are chance that there are lesser insulin requirement and dosing timing, with a lower risk of diabetic nephropathy and neuropathy, with improved muscle health and strength and function, with an improved bone health, lower risk of osteoporosis and bone fracture, and greater aerobic capacity and better performance, and will reduce all cause and disease-related mortality. There are some forms of cancer which have been seen to reduce by daily exercise. And there's an improved sleep duration and sleep quality. And there's improved glycemic control also. There's time in range or more, and there's a reduced percentage of time below range. There are possible risk of regular exercises are hypoglycemia, hyperglycemia, musculoskeletal soreness, angina, infarct, and damage to the fit if it is not properly dealt with, not properly evaluated with, and person goes on exercising, and worsening of already existing severe diabetes retinopathy. So, factors that may really influence the glucose response to exercises are exercise type, duration, and intensity. What are the type? You know, the exercise, the endurance exercise may rather decrease, it may cause more hypoglycemia, and whereas extreme, like, if you can see, there's explosive exercises may increase blood sugar level. It causes hyperglycemia. And here, if we go with that, there are exercise time of the day. This is very important concept in the children who are more active in the afternoon. There is a chance, there is a biphasic insulin sensitivity. At the time during exercise, there is an insulin sensitivity, and around after 12 hours, that insulin sensitivity prevails. Means there is a chance of hypoglycemia at around 2 to 3 a.m. morning hypoglycemia. Morning hypoglycemia. So that is very important. And the food consumed in past 2 to 3 hours, rate of change of glucose before exercise, and sex, menstrual phases, and sleep durations are all the features. Factors that might increase hypoglycemia that we know, that it's hypoglycemia in 24 hours, insulin on board, there's a concept, and lengthy moderate to vigorous intensity, and afternoon or evening exercise that may cause hypoglycemia in the morning hypoglycemia. These are the general trend of glucose trend caused by different type of exercise, like aerobic activity, which may cause that's endurance. Aerobic activities may cause hyperglycemia, severe aerobic activity, and finally, this anaerobic activity may cause hyperglycemia because there's a recruitment of catecholamines and lactates. And secondly, in aerobic exercises where there's a hypoglycemia, there are exercises like mostly aerobic which causes hypoglycemia, which we have discussed. Hyperglycemia may be caused by missed or omitted insulin dose, failed infusion site, competitive sport where there's a recruitment of catecholamines, excessive carbohydrate intake in setting of low insulin in board, and burst of explosive exercises, dehydration, stress of illness. Type 1 diabetes is associated with marginal impairment in skeletal muscle health and cardiorespiratory fitness. However, this impairment can be offset with good glycemic control and exercise training. What guidelines say that was very wonderfully dealt with previous orator. The children and adolescents with type 1 diabetes should have engaged in 60 minutes per day or more of moderate to vigorous intensity aerobic activity. And adults have 150 minutes or more of moderate to vigorous intensity aerobic activities per day, and it should be spread at least 3 weeks per week. And there is a session, and adults and type 1 diabetes and type should engage 2 to 3 sessions per week of resistance exercises on non-consecutive days. All adults, and particularly those with type 2 diabetes, should decrease the amount of time spent in daily sedentary behavior. Flexibility training and balance trainings are the key. Evaluation of baseline physical activity and sedentary time is a key factor. to assess for condition that can predispose to injury before prescribing an exercise regimen is of paramount importance, like to see the neuropathy, retinopathy, coronary artery disease, peripheral artery disease. And aerobic exercise to prescribe to a person living with diabetes, type 1 diabetes, to start with walking at a comfortable pace for at least 5 to 15 minutes at one time, and then gradually progress over 12 weeks to up to 50 minutes per session. And alternatively, there can be done one thing, there's shorter exercise session in a day, 10 minutes in 3 times a day after meals, can replace a single longer session of equivalent length and intensity, because body remembers everything what you do. And resistance exercises, like choose 6 to 8 exercise targeting the major muscles like chest, abdomen, arms, leg, and back. These are the group of muscles which can be chosen and gradually increase the resistance until one can only perform 3 sets of 8 to 12 repetition for each exercises. Then there's an interval training. There's a very important point which I wanted to draw your attention, that exercise in water is one of the important other type of exercises where the patient who is having osteoarthritis, they can do it, or a severe peripheral neuropathy, they can walk in the water, and that can reduce their pain. What are the contraindications? In a simple term, there's a severe hypoglycemia, severe hyperglycemia, and ketoacidosis. Optimal target is 90 to 270 milligrams without any ketoacidosis. This is an optimal window for exercise. Recent episode of severe hypoglycemia in 24 hours is a contraindication because it may cause again hypoglycemia. Severe hyperglycemia with ketoacidosis, if ketone is more than 1.5 millimole per liter and blood glucose level is more than 350, that is also a contraindication. And injuries like exercise with an injury is not recommended because it may precipitate hyperglycemia, and hypoglycemia may increase the risk of both acute injury and sustained. These are the factors considered before exercises, that we have to find out the lipodystrophy in the patients. We have to find out, we must know that rapid acting, irregular and intermediate acting insulins may absorb more during exercise, but probably not long acting insulins. And there are many other features which we can read it out. And there's a glycemic management during exercises or blood glucose. If blood glucose is less than 90, then we should treat that patient ingesting 10 to 20 grams of fast-acting carbohydrate, depending on the body weight, and to delay exercise until blood glucose comes over 90. And then 90 to 125, we should give a person with diabetes 10 to 20 grams of supplemental carbohydrate before starting aerobic exercises. And if it is 126 to 180, then we can start exercise, we can allow him to exercise, but after 30 minutes, we tell him to take 10 to 20 grams of carbohydrate. And if it is 180 to 270, then the person can go ahead with exercise, except that it should be around 30 to 60 minutes. Then again, we should check the blood sugar level. These are the carbohydrate requirement for endurance exercise. This is a point which you can read it out, but it's very important. And finally, guideline for reduction of pre-meal dose of rapid-acting insulin is a low, if a person is going for a low intensity exercise, like where oxygen consumption is less than 25%, then if he's going to go for 30 minutes of exercise, then 25% of insulin should be reduced. And if it is 60 minutes exercise, then it is 50% of the pre-meal insulin should be done. So we can go with this type of reduction in insulin. And strategies to reduce insulin on board for endurance exercise. There is the person who is on multiple daily injection, lower basal insulin by 20% if the person is on faster state. And early post-meal exercise within 2 hours after meal, then lower bolus insulin by 25 to 75%. And if a late post-meal, there is no requirement of insulin dose changes. And there's a decision tree for aerobic exercise and mixed aerobic and anaerobic activities. So, to cut the long story short, regular exercise promotes enhancement of insulin sensitivity, increased cardiorespiratory fitness, maintenance of healthy body weight, and potentially improved glycemic control for individuals living with type 1 diabetes. Poorly managed glycemia in type 1 diabetes is linked to reduced aerobic fitness, reduced muscle oxidative capacity, and deterioration in ability of muscles to adapt and repair for vigorous exercise. Several factors other than exercise mode influence the glucose uptake. That is time of the day that we have discussed, insulin board, nutrient intake, exposure to hypoglycemia, and the use of small doses of solubilized glucose taken just before exercise shows. So exercise matters, and matters a lot for many different reasons. Thank you so very much for patient hearing.
Thank you, Supriyo. Excellent presentation. Please, audience, get ready with your questions. I have a small question to you. You, in your opening remarks, said that patients of type 1 diabetes in India are prescribed very little exercise and they do very little exercise. Where is this data from?
Yeah, this data, this is a very important question, sir.
Yeah.
But we generally, I thought that we as a physician, generally avoid talking exercise and length with our patients. Generally.
No, that's perfectly all right.
Yeah.
I mean, I'm not talking about personal experience. Do we have data from Indian patients?
I don't know,
data?
sir. I don't know.
Okay.
There is a widespread perception that exercise, even for doctors who are that excessive exercise, running, walking will damage knees and all those things. Basically, exercise is a very scientific thing, and core exercise have to be combined with cardio to have proper injury-free, long-duration exercise. So all those things have to be learned by us actually, so we really can teach the patients to do exercise.
What I was pondering, sir, the questions, that if we can have a survey here. We can just have a survey here that is basically a clinically thought and research thought, scientifically thought that how many us really prescribe prescription.
No, that's
that is very important.
My intention of asking this question is to give a lot of inputs to Subhash, because he always asks me topics for research.
Yeah, that is the point.
So, you know, keep noting down all these things. We can come out with wonderful, data pertaining to all these gaps in our understanding. This is another one that I just showed to you. We hardly have any data in type 1 diabetes. We do have this data in type 2 diabetes.
Yeah.
The INDIAB study has gone into depth of the entire issue. The gamut, that the amount of exercise, type of diet, amount of everything is there. But in type 1 diabetes, at least I am not sure if other experts sitting in the audience, if you know any Indian data. If not, this is a very nice topic for research.
And
any other question from the audience?
Sir, at the very outset, I started with this because this is a question. This is a research question. Why we don't?
Exactly. Okay, excellent. So this was very nice. Thank you very much. We move on to the next presentation.
Thank you.
Thank you, Supriyo. Thank you very much. Which is the next topic, Kamran?
but then I think chairpersons will change.
ये change हो गया formality होगी.
Okay.
Yeah, thank you so much, chairpersons. I'll request the speakers to please come on the dais for the felicitation. Speakers, yeah, Dr. Subhash and Dr. Supriyo sir, please come on the dais. I'll request the chairpersons to honor the speakers with a bouquet. And Dr. Supriyo sir.
Dr. Akash.
And I'll request the speakers to honor the chairpersons with a bouquet. A big hand for our chairpersons as well. Thank you so much, speakers and chairpersons. May I request chairpersons for the next session, Professor Dr. Binay Kumar sir, to please come on the stage, and Dr. Santosh Kumar Singh sir.
I have the pleasant task of inviting Dr. Akash from Vadodara, and he will be highlighting us on the modifiable ASCVD race. It's definitely a talk which we all thrive for, and we will be talking about diabetes, hypertension, dyslipidemia, obesity, and the important is we can modify these factors which can lead to the ultimate complications in diabetic practice. So Dr. Akash.
Thank you, chairpersons. Thank you, the entire team of RSSD BIHAR to call me here. It is indeed a pleasure to come here and talk. And today I will be talking on the same lines as have been the previous lectures, that is the ASCVD risk reduction. Now, atherosclerosis is a multifactorial systemic process that progresses at various rates in many vascular territories. Consequences of genetic predisposition and exogenous risk factors. Acute clinical manifestations of ASCVD triggered by subset of atherosclerotic lesions. It is a leading cause of death and morbidity worldwide. It shows a considerable heterogeneity both in genetically healthy persons and those with known ASCVD population. Foundation of preventive cardiology begins with assessing baseline ASCVD risk using global risk scores based on standard office-based measurements. Additional risk enhancing factors including both traditional and novel biomarkers and inflammatory factors can be used to further assess ASCVD risk, especially in those at borderline or intermediate risk. There are also female-specific risk enhancers, social determinants of health, and considerations for high-risk ethnic group. Screening for subclinical atherosclerosis, especially with the use of tests like coronary calcium screening, can further inform the treatment decision-making if patients are in borderline zone. Patients with pre-existing ASCVD also have variable risk, and that also we have to identify. Current guidelines also define high to very high risk ASCVD. Accurate ASCVD risk assessment is crucial for the appropriate targeting of to reduce ASCVD risk. And lastly, a very good interaction with the patient. That is a clinical patient interaction is utmost basically if we have to convince the patient to take therapy lifetime and reduce the ASCVD risk, without which nothing will be possible. Now what is atherosclerotic cardiovascular disease? Clinical is MI, acute coronary syndrome, stroke or TIA, aortic aneurysm, peripheral artery disease, any arterial revascularization. Unequivocal ASCVD on imaging, that is plaques on coronary angiography, plaques on CT coronaries, plaques on carotid ultrasound. So any vascular territory involved anywhere will form ASCVD diagnosis. The prevention which is there for ASCVD is at 3 levels. Primary prevention, which Dr. Maheshwari was talking about, is at the population level, starts right from pregnancy and to spreads to the large population in form of healthy lifestyle and healthy eating. Primary prevention is addressed to those whose ASCVD score defines them into moderate or severe risk category, and secondary and tertiary prevention is at the when there is established atherosclerotic cardiovascular disease. So if you see the subclinical atherosclerosis, small plaque, we should begin basically at this level of prevention to prevent future atherosclerotic cardiovascular disease and to reduce the burden of atherosclerotic cardiovascular disease in the future. And this begins at the level of primordial prevention and then the primary prevention, and once there is established cardiovascular disease, then we have to go for secondary prevention. Risk factors, there are multiple risk factors which are traditional and non-traditional risk factors, which we will see in detail in the subsequent slides. Now, assessment of cardiovascular risk should be done in all adults between 40 to 75 years of age using the standard scales which apply to the population. For adults 20 to 39 years of age, it is reasonable to assess traditional atherosclerotic cardiovascular risk factors every 4 to 6 years. In adults with borderline risk, you have to go for further tests like coronary artery calcium to stratify the risk and to then interact with the patient for treatment. Why is the risk assessment of ASCVD important? The higher the absolute severity risk, the higher the absolute benefit of risk factor treatment, lower number needed to treat to prevent one CVD event during the period of time. That is why the estimation of CVD risk is cornerstone appearing at the forefront of proposed management schemes. Lifetime risk is very important because for younger population, all the risk assessment tools do not stratify risk. If this younger population has even one risk factor for future cardiovascular disease, it can lead to ASCVD at the age of 40, 50, which is undesirable, and therefore we have tools to assess the lifetime CVD risk, and then we can take the patient into confidence and start treatment in this patient. Residual CVD risk is addressed in those patients who already have established atherosclerotic cardiovascular disease. We have taken care of the treatment part, we have taken care of the risk factors. Then there are certain other diseases which impart this residual risk, and that those diseases also have to be taken care of. The residual 10-year CVD risk after general prevention goes depends on age, presence of ASCVD, kidney function, adequacy of risk factor control, risk modifiers, comorbidities, and calculation of residual risk with a calculator. The calculator scales are different for patients of established ASCVD. So the risk stratification which we do is generally more so in the apparently healthy people. It is different basically in patients with established atherosclerotic cardiovascular disease, and strong risk factors like diabetes, familial hyperlipidemia, and CKD basically will tell us to put this patient to very high risk category. Now this is the ASCVD risk score, which has further been modified to ASCVD risk estimator plus with incorporation of the pool cohort equation risk score equations, which provide more updated 10-year ASCVD risk estimates for those aged 40 to 49 years and lifetime ASCVD risk estimate for those aged 20 to 59 years. So this ASCVD risk estimator plus is a better version of ASCVD score, and it classifies the population low risk, borderline risk, intermediate risk, and high risk. And if the patient falls into borderline risk or intermediate risk, you have to go for other tests with consent of the patient to stratify the risk further. Framingham risk score is best known and unarguably the most widely adopted model globally for risk assessment. The Framingham risk score estimates the 10-year risk of manifesting clinical CVD. Earlier we used to go for fatal CVD assessment, but now we also assess non-fatal CVD risk. However, the definitions of non-fatal CVD risk vary from country to country and are not standardized. Still, this has been incorporated in all the later risk assessment scores. For identification of high CVD risk group Indians, the Fleming risk CVD assessment model is most useful. The Q risk score, this is a British score which applies better to Indian population, and there is a modified Q risk score which also takes into consideration the smokeless tobacco, that is a chewing tobacco which is very popular in India, and that is why the modified Q risk score is very important as far as the Indian population is concerned. The European, the ESC score, or the score to algorithm, which is up to between 40 to 69 years of age, and 70 years and beyond, they use the scores to algorithm. The limitations of current risk assessment score, majority of those eligible are generally beyond 60 years, and you know that 50% of CVD events occur in men and one third of women before 60 years. So at younger populations, they do not work well. Interference with chronic processes leading to ACVD implies necessity for early and preventive treatment, which is missed in younger population. Conventional strategies for assessing CVD risk and for guiding stating eligibility for cardiovascular prevention do not entirely capture genetic susceptibility to CVD, and for that polygenic risk score is used. Current guidelines-based clinical risk assessment algorithms do not optimally reflect risk, particularly in those who are young and at high genetic risk. There is a variability of scoring in diverse racial ethnic groups, less ideal for accurate risk prediction in patients already receiving intensive preventive efforts, may overestimate risk in groups with predicted 10-year risk more than 10% in higher socioeconomic status and in those receiving intense treatment. Underprediction of risk may be seen in patients with lower socioeconomic status and those with chronic inflammatory diseases. Limitations specific for Indian population, no risk prediction model validated for Indian populations. 10-year CVD risk score calculators do not behave same in Indians as in Western population. Smokeless tobacco is not covered in majority of the risk scores. Now coming to the temporal trends, these are the longitudinal trends in the overall incidence of cardiovascular disease, and it is done in US, and it was seen from 1919 to 2013. There was a linear decrease in the prevalence of CVD, but again this has risen basically. So you can see the ASCD prevalence was going down, that again has risen. By income category also has risen, by race also has risen, and by sex also has risen. This is despite the fact that we are controlling LDL better, HDL is remaining static, we are controlling diabetes better, we are controlling LDLC better, we are controlling triglycerides better, and with the smokers are less. And the reason is that the BMI, diabetic prevalence, hypertension prevalence, and the systolic BP prevalence has increased, and the overall number of patients are increasing basically, which is leading to higher prevalence, and more patients are going for older age, thus increasing the numbers of patients with CVD. So there is a demographic trend for increased numbers, and this calls for integration of efforts aimed at prevention of CVD, including primordial prevention of CVD risk factors. Now coming to risk enhancers and their role. Why risk enhancers are important? Because if you have a patient at borderline risk, then you have to go through these risk enhancing factors, and if present, they will qualify the patient to receive statin therapy, and it will also convince the patient to take statin therapy. And these are family history of premature ASCVD, that is males ASCVD less than 55, females less than 65, primary hypercholesteremia, metabolic syndrome, chronic kidney disease, chronic inflammatory conditions, history of premature menopause, PET, high risk race, ethnicity, lipid biomarkers associated with increased CVD risk like persistently elevated triglycerides, elevated CRP and CRP, elevated LPA beyond 50, elevated FOB, and ankle brachial reflex less than 0.9. And if there is a borderline zone, you can go for CSC measurements. Less than 100 is low risk, 100 to 400 is intermediate risk, and more than 400 is high risk. However, if patient has absent coronary calcium, he still can have soft plaques, and rarely these patients can develop acute coronary syndrome. So this is how you quantify the ASCVD risk, and if you have intermediate risk population, you go for further tests basically to quantify the risk. Now as far as the risk factors are concerned, non-modifiable risk factors and modifiable risk factors. The non-modifiable risk factors obviously is age basically, and any men more than 65 and women more than 75 are almost always at high 10 years CVD risk. The age ranges may differ according to men and women and geographical regions. The modifiable risk factors are all these 5 mentioned. Coming to cholesterol, it is always better to have LDL less than 55. It has a lower risk of ASCVD. The relative reduction in CVD risk is proportional to the absolute size of reduction of LDL-C, irrespective of drugs used to achieve such reduction. The benefits of lowering LDL-C depend on the absolute risk of ASCVD and the absolute reductions in LDL-C. So even a small absolute reduction in LDL-C may be beneficial in a high risk or a very high risk patient. The non-HDL-C is important if your triglycerides are remaining beyond 200. The relationship between non-HDL-C and CV risk is as strong as the relationship with LDL-C. Non-HDL-C is used as an important input in the risk scoring systems. HDL-C is also very important. Low HDL-C basically is an important marker of ASCVD. However, the strategies addressed at increasing the HDL levels have not resulted in reduction of CVD events, and therefore HDL-C is relegated to be a marker of atherosclerotic cardiovascular disease rather than having any therapeutic intervention strategy as of now. Triglycerides, hypertriglyceridemia is significant independent CVD risk factor, but the association is far weaker than for hypercholesterolemia. Meta-analysis suggests that targeting triglycerides may be beneficial in patients of diabetes and metabolic syndrome where there is a low HDL and high triglycerides. Familial hypercholesterolemia does not qualify for all these risk scores. It has a separate scoring system altogether, and specific LDL targets are set for these conditions. If there is a familial hypercholesterolemia without established ASCVD, then you can qualify this person as high risk, and if there is established ASCVD, then this patient falls into a very high risk category. Blood pressure is very important because elevated BP is associated with coronary artery disease, heart failure, atrial fibrillation, cerebral disease, CKD, lower extremity arterial disease. The risk gradually increases from systolic BP 90. As the BP goes beyond 90, gradually the risk increases linearly, and for diastolic BP beyond 70. The absolute benefit of reducing systolic blood pressure depends on absolute risk and the absolute reduction in systolic BP. We have 3 different methods of measuring BP, that is office BP, the home-based BP, and the ABPM. And the home-based BP is 5 to 50 millimeters less than the office-based BP. In the gender difference, the females are more sensitive to BP rise compared to male, and secondary hypertension does not qualify for the ASCVD risk prediction with the present scoring systems. It has to be tackled differently. Now coming to diabetes, type 1 diabetes and type 2 diabetes and pre-diabetes are independent risk factors for ASCVD, increasing risk by about 2-fold. Patients with type 2 diabetes are likely to have multiple ASCVD risk factors, including dyslipidemia, hypertension, each of which mediates an increase in risk of both ASCVD and non-ASCVD morbidity and mortality. The risk magnitude type 2 diabetes doubles the CVD risk and reduces life expectancy by 4 to 6 years, with absolute risk highest in those without any target organ damage. Type 2 diabetes also increases the risk for cardiorenal outcomes, in particular heart failure and CKD. Risk reductions for CVD in type 2 diabetes are higher in younger ages, younger age of onset, and are modestly higher for women compared to men. Type 1 diabetes, the risk is higher basically because the duration, because this starts at a younger age, and the duration is always more than type 2 diabetes at a particular age. Early manifestation of type 1 diabetes relates to more life years lost in women than men, mostly due to CVD. The absolute risk of CVD events or CVD mortality is highest amongst those with any evidence of microvascular disease, particularly renal complications, and is strongly influenced by age. Is diabetes a coronary artery disease? We cannot know if it is well controlled and of short duration, then it is not so. But if diabetes is 10 years or more in duration, and if there is a micro or macrovascular disease, this is definitely so. So basically we classify the diabetics into 3 categories: moderate risk, where their duration is less than 10 years, no evidence of target organ damage, and no additional ASCVD risk factors. Patients with type 1 diabetes above 40 years may also be qualified according to these criteria. It is high risk if patient falls in between the very high risk category and the high risk category, that is 10 years or more diabetes without target organ damage, and if there is a target organ damage and established ASCVD, then this is a high risk situation. So diabetes with established ASCVD, patients with diabetes and established CVD have higher vascular risk and lower life expectancy than those patients of CVD without diabetes. So basically they have to be advised smoking cessation, adoption of healthy lifestyle, risk factor treatment. Most patients are at high risk for CVD events, and you have to also look at the risk modifiers, comorbidities, treatment benefits, frailty and patient preferences, and subject these patients for treatment. If they have associated CKD, then the risk is even higher. Adiposity, it is seen that BMI 20 to 10 to 25 is the best BMI basically. If BMI is more or if the waist circumference is more, these factors are strongly associated with ASCVD and type 2 diabetes. But there is a fitness paradox. If obese patient is fit, basically is on regular exercise, then his risk may be as good as normal weight individual. So not only overweight but fitness also is a factor basically as far as this thing is concerned. And cigarette smoking obviously is a high risk proposition, and e-cigarettes also there. E-cigarettes basically can only be used to help the smokers quit smoking. They also have some degree of severe risk. So cigarette smoking has significantly higher severe risk. It raises the BP, CVD mortality, insulin resistance, and everything basically related to ASCVD. These are the risk modifiers which we have to look basically, and they also have to be tackled. But the risk modifiers are not having the same strong association with ASCVD as risk factors. These are postulated to have, but they are not great studies basically to substantiate their effect, and controlling this leads to amelioration of ASCVD is also not proved by large scale studies. So I'll just come to the, these are the comorbidities basically which increase the risk of ASCVD, and all of them have to be tackled amicably to ameliorate the risk of ASCVD and to prevent the future ASCVD events. So to summarize, ASCVD is a leading cause of death and morbidity worldwide. Estimation of absolute risk of developing incident CVD event is the foundation of current approaches to primary prevention of CVD. Current guideline-based clinical risk assessment algorithms do not optimally reflect risk, particularly those who are young and at high genetic risk. No risk prediction model validated for Indian population. Framingham risk score is the best known and unarguably most widely adopted model globally. Q-risk score seems to work very well in Indians. Despite better control of diabetes, lipids and other risk factors, prevalence of CVD is increasing due to increasing prevalence of these diseases and increasing numbers of elderly population. Taking care of modifiable risk factors like diabetes, hypertension, obesity, lipids, smoking improves prognosis. The risk modifiers and existing comorbidities should be considered in the preventive strategy of atherosclerotic cardiovascular disease. Thank you.
Thank you, Dr. Akash. Wonderful talk, very informative. We can have some questions from the floor. Questions, comments? If not, couple of points. You mentioned everything. So, recent studies have come up with the variability part of glycemic variability and blood pressure variability, remarkably affecting the mortality part. The mention about CRP, I think somehow it was not there in the whole number of slides. It's very important, and in patients with family history, I always look for homocysteine. Family history, no risk factor, lipid profile normal, and in them I often come across hyperhomocysteemia. We know that there are no studies showing that by controlling homocysteine you can affect the mortality part. But definitely it is a modifiable risk factor which we should think of. Regarding the obesity part, I just gave a comment on that. The importance of truncal and more so the hepatic fat. There was a recent Masala study, the name is so catchy, mediators of atherosclerosis in South Asians living in America. A very nice study, the whole spectrum of ABCD, including diabetes, obesity, everything. And that emphasizes on this point. The visceral obesity is responsible for a whole lot of complications, starting from diabetes to diabetes and the complications. But hepatic fat is very important in the progression from pre-diabetes to diabetes. And hence the importance of the primordial modification and primary modification to take care of all these complications. Thank you. Very wonderful talk.
Thank you, Dr. Akash Singh, for your elaborate deliberations and nicely summarized and moderated by our chairperson. We have seen the expression of Dr. Akash Singh covering all the areas regarding ASCVD and diabetes as such was there, but he covered many of the topics. Sir, जैसा कहा CRP is also important. Prognostic value of CRP itself is very important. And the spectrum which you covered, I think it was very excellent, praiseworthy. Thank you very much for your deliberations. Mr. Manish.
Now it's my again a pleasant task of inviting Dr. Amit Gupta, and he will be wisening us with diabetic technology, which we are all waiting for. Amit, please.
Thank you, sir. And thank you, Dr. Akash Singh, sir, and Dr. BK Singh, sir, Dr. Subhash, for inviting me here, Dr. Ajay, sir, for this invitation of RSSDI BIHAR chapter. And previous two speakers have set the agenda with technology, some part with exercise and some part with CVS reduction. So my task is to talk about diabetes technology. So it is a huge subject. It itself is a topic that requires 2, 3, 4 days of conference, and there is a big meeting happening in Europe, ATTD, and we will also have one meeting in India also. So I thought I will be taking you through a journey of diabetes technology, what is available and what is expected to come in the near future. And I hope you will find it exciting. So when we talk about diabetes technology, there are two things which are very, very common. That is the glucose monitoring and the insulin delivery. We know that the way we are monitoring glucose, it is changing. And also the way the insulin is being delivered now, it is also changing. We have apps, we have softwares. We are talking about the digital therapeutics also. We talk about role of technology in management of diabetes complications. There are newer targets which are being developed. We talk about adipose tissue as one of the another target where things can go to the next level. Stem cell is something, and the gene therapy is something where more technological advances can actually guide what is happening. So this is just a brief snapshot that how the technology has changed in the commercial aspect and how it is changing in the monitoring aspect. So if you look at, if you just go back 30 years before, you will find a very small device or a gadget in your hand playing some games, and I think all of us must have played those kind of games where the water is put into some device and we just press buttons and rings, we need to put them into some bars. So, but now we have Xbox, we have PlayStation, the gaming has gone into virtual reality. Similarly, the glucose monitoring is also changing. We had tested glucose through the urine, through the blood, now then came the glucose meters, then came the CGMs, and now we are talking about the non-invasive glucose monitoring and the monitoring of the glucose from the other body fluids also. So this is just a passing remark. Now we have connected glucometers. These connected glucometers gives you an advantage that they are connected with your smartphone. Some of them, they directly plug into your smartphone, while the others send the data to your smartphone through the Bluetooth. So you are able to digitalize the data. So this is one application of technology where you need not to maintain the logbooks in the form of papers. You can maintain the logbooks in your digital diary, which is available with most of the glucometer devices. These are the 3 CGM devices which are commonly available. One is, you can, on the right side you can see the Medtronic device, that is a Guardian Connect. Then you see the Dexcom. Dexcom is still not available in India, but very soon Dexcom is coming to India, and they will be launching this year the Dexcom product in India. And this is the Libre 3. We are using only Libre, but this is the Libre 3. This is labeled as one of the smallest sensor in the world. So Libre 3 is available globally, but it is not yet available in India, but we hope that it will come in near future to India also. So these are the 3 CGM devices which are available for the continuous glucose monitoring. Another one is the Eversense. Eversense is a implantable glucose sensor. So this has to be implanted under the skin. The first generation of the Eversense sensors, they were able to record the blood sugar for 3 months. The second generation, they were able to record the 6 months. Now the Eversense has launched a new generation of the sensor which will be able to record the blood sugar for the entire duration of 1 year. So this is a invasive device, but it is placed subcutaneously. So glucose monitoring technology is changing, and we know that there are advantages and disadvantages of each and every category. We have SMBG and we have CGMs, and then we have flash glucose monitorings also. Just to give you a snapshot that how a CGM report in the Libre, which is most commonly used, things look like, and how it can help us in intervening this patient. If you look at this, this is the AGP of or 14 days profile of a patient. You will find that most of the time glucose levels are on the upper side, out of the range in this case. But if you look at the 14 days chart, you will find that with the use of the technology, if you follow the patient regularly and you are able to intervene and guide the treatment. So on day 1, on the 11th of March, this patient had very high blood glucose levels ranging from 238, 270, 283. But if you look at the last half of this chart, you will be able to see that the patient is very much controlled. So this can happen once you are able to visualize the data, you are able to understand the diet, you are able to guide the therapy also. So we will not go into the details at what kind of intervention was done, but this is something, if you are able to look at the data, you can actually change and intervene at a faster pace and bring down the glucose level and maintain the glucose levels. This is just a comparison of different CGM devices, the Guardian Connect, Dexcom G6, Libre, Eversense, and another one, the Metron, which is still not available in India. We know that patients with diabetes, they are often prescribed on complex insulin regimes, and this can hinder patients' glucose management. So most of the patients, they find difficulties with taking insulin at prescribed time or with meals every day. There are difficulties following healthcare professionals' instructions, and their physicians, most of the time we agree that we have difficulty in initiating patients on insulin, and if we have to prescribe insulin for multiple daily doses, again it becomes a challenge. So saying almost more than 50% of the patients, doctors, they say find difficulty in changing timing of insulin to meet daily needs. So insulin pumps, they are available and they are used widely, especially for the people with type 1 diabetes, and now it is a global standard that in most of the countries, especially in the European world, now 90% of their patients are on insulin pumps. We are still very in the initial phase of using insulin pumps, but they are available. I will just show you these two devices. One is the Medtronic 670G, which is available in India, and this is an automated insulin delivery device which is combined with the Medtronic sensor. On the other hand, you can see that this is the T-Slim T5 tandem device, which is not yet available in India, but it is commercially available in Europe as well as the US market. So this is another insulin pump which is available. We have Ipsomet. You can see these three different colored insulin pumps. This is the Ipsomet pump which is also available in India. And and you can see this is the Omnipod. The Omnipod is an insulin patch. If you see in the previous two devices, there is a need for the cannula, and there is a which connects the insulin pump to the subcutaneous infusion set. But in this patch pump, there is no cannula. So the insulin pump is directly placed on the skin itself, and then disposable pumps are also available. So these disposable pumps, they may not be, we are not talking about the cost right now, but we are talking about the technology which what is available at this point of time. So I think in near future, we would like to see our patients using technologies in the form of apps which are helping them, the monitoring devices which will again be helping them. This is the Omnipod, how it works. This is the Omnipod 5 app. There is a port, and it is connected with the Dexcom G6 sensor. And this is how the entire network works. I will not go into the detail of this. And now a lot of patients, they are doing DIY, that is a do-it-yourself kind of technology also. They are looping their CGM devices, and they are also guiding their own, developing their own algorithms for the different insulin pumps, and they are able to achieve a very good glycemic control with that. We also know that even in type 2 diabetes patients, there are frequent errors with the insulin dose delivery, and this can lead to increase in HbA1c. Many of the time patient will experience a single episode of hypoglycemia and will stop the insulin altogether, or sometimes they will not remember what dose they, so they will confuse with the dose because they keep changing the doses. So this is just one study which shows that almost 24% of the patient, they will miss the bolus dose. Again, 36% of the patient, they will miss the basal dose, or they will mistype the basal dose. So, and 2/3 of the patient with type 2 diabetes, they have poor treatment concordance whenever they are put on any kind of insulin therapy. So can something be done with that? So very soon the Sanofi is coming to India with connected pens, and these connected pens will be having a smart cap, and this cap will be connected to an app on your phone. So every time a patient takes a dose of insulin, so we just saw this device at the ATTD in Berlin. So whenever you give a dose, this dose will be recorded automatically in your app, and there are sensors also which will be coupled with this app. So patient will be able to see the glycemic patterns also, as well as they will be able to record their doses for the monitoring purpose. So there are many studies which shows that smart connected insulin pens in patients with type 1 diabetes. Smart connected insulin pens in patients with type 1 diabetes. So whenever they were using the connected pens, definitely they had missed few doses, and this was allowing the patients to adjust insulin when physically active, ensuring safe exercise performance also. So this is what I wanted to highlight. So people with type 1 diabetes, they can exercise very well. If they are able to monitor them, then they can prevent hyperglycemia as well as hypoglycemia. I met one of the person in a gym, and he was a type 1 diabetic patient, but he was wearing a Dexcom G6 device. He was on insulin patch pump, and he was not looking anything less like a bodybuilder. So that person was exercising like anything, but was preventing hypoglycemia, and his HbA1c was somewhere between 6 and 6.2 only for last couple of years. So this is how the technology can assist in keeping a good HbA1c level. So I will not go into details of all this, but the food tracking and the carb counting apps are available, which can help our patients in recording their food habits. They can guide the patients in counting the calories also. Now there are apps where a patient can simply take a photograph, upload it, and within few seconds the patient will get the calorie count of that meal. So this is something which is available also, and in India 7 Sugar is one of the company which is doing so, and the app is freely available on the App Store. Activity tracking, I think most of us are now track our activities in terms of steps. We count our daily different kind of exercise activity also. So activity tracking is again very, very important and can help people in developing good healthy behaviors. So there are studies also that have shown that if you are able to track, you are able to change yourself. So behavior can also be modified once you are able to track things. Now glycemic profile, we know that CGM readings can also come with the help of the connected meters. Patients can also have their own dashboard, and the doctors can also have their own dashboard. We know that whenever we put the patient on insulin, it is difficult to handhold the patient for next few days or few months just to titrate the doses or guide the doses. Now there are validated insulin dose calculators which are available, and these insulin dose calculators can help the patient in intensifying or de-intensifying the insulin therapy based on their glycemic levels. Digital therapeutics. Digital therapeutics is something which requires prescription, and there are a couple of digital therapeutics which are available in the European market, and they are given as a part of prescription only. So when patient is able to use these kind of digital therapeutics, they are able to modify their behavior, they are able to have better control of their glycemia. Coming to some complication part, we all know that AI-enabled fundus camera is something which is now almost a decade India is using, and these devices are very helpful in artificial intelligence-based detection of the retinopathy, and the detection rates are also very good in these cases. This is something, one of the customary sensory insole. Here, the patient is given a insole which is connected with which is having sensors. These sensors can actually sense the temperature and the changes, and they can monitor pressure, step count, hours of use and temperature. So this provides real-time audio-visual alerts and offloading instructions when sustained high pressure level occurs. So somebody who will be at high risk by wearing these soles can actually avoid prolonged pressure on the designated areas. Also, this is AI-based multispectral wound image, and this is just to show you that on one image you will find that the Illuminate report shows that gram-negative bacteria, and the culture report was also Klebsiella species. And in another image you will see that the Illuminate report suggested that it can be a gram-positive infection. So those people who are working extensively in the area of foot disease, especially Dr. David Armstrong is doing amazing work in this field, and he is very much using this technology for the early detection of what kind of infection and predicting what kind of infection is there. So the culture report will take any time around 48 to 72 hours, but with this imaging you are able to at least guide the initial antibiotic therapy in these cases. This is siren socks. Again, this is a siren socks which is wear siren socks daily, and this gives regular feedback about the temperature, and if any early injury or any bleach happens, this can also detect. And this is a study that shows that those patients, the intervention group received pressure sensing technology and provided audio visual alerts and offloading instructions. when elevated pressures were detected, and there was improved outcome in these patients. What is all these? What I have shown is that is available in some part of the world, but this is something which is coming now. We also know that CGM has a small filament which is placed under the skin, but now we will be having these kind of devices where even the filament will not be placed under the skin, and many of these devices are based on Raman spectroscopy, which is one of the method of detecting blood sugar level. This is, you can see Dr. Manoj Chawla here and with Dr. Bansi Sabu holding one device. This is one device which is validated, and very soon it will be hitting the market. This device can screen the blood sugar level simply by placing your thumb over the device. So it is good for a screening device, and it can be a very handy device in the mass screening or the mass population where actually you don't need to. So this is something K-Watch, and now many devices of this like are in development, where that watch will be having some sensors which will be able to detect the sugar levels in the blood. This is again very interesting device which we just witnessed at ATDD. This is a breath-based glucose monitoring system. So now when we were entering the Bihar border from the Jharkhand, they were testing the alcohol level, and we all know that the alcohol level can be detected by the breath analysis. So this is a device which can detect the glucose level by breath analysis. So this is under FDA, not FDA approved, but under a lot of research has already been done. This device was displayed, and we saw the results practically, and we compared with the blood sugar levels with the capillary glucose levels also. But this is something which is available. These are other devices like D-Base, D-Pocket, D-Sensor, which we have, which are available, but not commercially available. But a lot of research has already been done, and they can non-invasively sense the glucose levels. Skin patch is something which we are talking about a lot of time, but this is something which can sense the glucose levels through these differently placed sensors. Also, this is something which is coming up very fast, non-invasive health screening, though a lot of more research is needed, but there are a lot of startups which are already working in this area also, whereby simply screening or by thermal images of the body, they will be trying to establish certain kind of patterns. So this may or may not be possible, but this is something where the future investigators are looking at. In smart artificial pancreas, we know that the problem with the pancreas is that whenever the transplantation, we talk about the pancreatic transplant, the problem is that the cells, the rejection rate is very high. But the BioSite is now working with a model where they have developed a membrane kind of structure where the transplanted cells do not come actually into contact with the antibodies which may be developing. So this is what the BioSite is doing. So this is BioSite, which is developing a functional cure for type 1 diabetes in the form of beta cell transplant. Now it has been purchased by the Vertex. Another important thing is that many companies are working with for streamlining cell therapy production and the stem cells and other therapies and the other aspects also. So I think I concluded in time. So with this, I would like to invite all of you for the World Congress of Diabetes Technology and Therapeutics, a 3 days treat for those who are interested in learning more technology, including insulin pump as well as the CGM Academy. So I would request all of you to be there. Thank you. Thank you so much for your patience listening.
Thank you, Dr. Amit. I assured everybody that we will definitely be wiser after his talk. So if anything to be known extra, you are free to ask him.
Sir, most of these devices are still not validated and are not FDA approved. So we are waiting for a device which will be FDA approved, and I think we are not very far from that. The first GlucoWatch came almost in 2004. So this is happening since more than 2 decades. But now I think we are very close to that.
I believe the Apple have sent a wall for FDA approval.
Sir, it is not yet, there are news reports about that, but it is still not, we don't know anything research or anything about that. So once it comes, I think it will be a game-changing technology for everyone.
Thank you, Amit. So I myself, with behalf of Dr. Binay, thanking you all for this for not very active participation, but very It was very knowledgeable session for that matter. Thank you all, and thank you the organizers for inviting us over this change. Thank you.
Thank you, chairpersons, and thank you, speakers. May I request also the first speaker in this session also please come on the dais, Dr. Akash Singh, sir. And may I request chairpersons to first honor the first speaker, Dr. Akash Singh. I know it's a bit late in the day, but a big hand for our speaker. Just come all the way from Vadodara and get a better speaker. May I also request Dr. Amit Gupta from Delhi to please join us, sir. A big hand for Dr. Amit Gupta. And I'll request the two speakers to honor our chairpersons with a bouquet. A memento for Dr. Santosh Kumar Singh, sir. Now, moving on to the final session of the day, may I request the chairpersons, Dr. Ajay Kumar sir, again to please come on the dais. Dr. Amit Gupta. Dr. Amit Gupta sir, I will request you to please keep your momentum and share the next session. And Dr. Hemshankar Sharma sir. Dr. B.K. Singh sir can chair the session.
So it's time for Dr. Arvinda's talk, and Dr. Arvinda is Executive Council member of National RSSDI, and he has come all the way from Bangalore for this RSSDI Bihar chapter meeting. And Dr. Arvinda is a very dynamic speaker and very well-known figure in the world of diabetes. So Dr. Arvinda, over to you for your talk.
Good evening everybody. At the outset, I thank Bihar RSSDI, Dr. B.K. Singh sir and Dr. Subhash and Dr. Hemshankar Sharma sir for making me a part of this conference. So after a wonderful talk by Amit Gupta about the various aspects of digital diabetics, if you take in Bangalore airport today also when we left in the morning, they were asking about Digi Yatra. So they were asking, you have Digi Yatra, then it will be easy. So that's the reason in the coming 5 to 10 years there will be a lot of revolution. My talk is on the basic aspect in the sense how Amit has discussed about the newer technology. I thought that we'll come to the basic and we should know the pathophysiology of type 2 diabetes, that is the ominous octet. So first of all, greetings to all of you from Bangalore. So from the triumvirate to the ominous octet, a paradigm for the treatment of type 2 diabetes. So 20 years back, if you take, there were only 3 reasons for the development of type 2 diabetes. Now, as the age advanced, we are more understanding the pathophysiology of type 2 diabetes. In the same way, the more and more molecules are coming into the picture. That is where the more evidence-based medicine what we are practicing right now. So we should probably say that is diabetology is one of the field where we practice evidence-based with the newer molecule and the newer understanding of type 2 diabetes. I am sure this ominous oxidase is only 8 reasons. I am sure in coming days there will be plenty of other reasons in the understanding of type 2 diabetes. If you take, it all started with the triumvirate, that is impaired beta cell function, increased hepatic glucose and insulin resistance. So 20 years back, people used to say, what is there in type 2 diabetes? You just diagnose type 2 diabetes, put metformin, sulfonylurea, if not put them on insulin, that's it. That's the end of the session for type 2 diabetes clinic. But as the day advanced, we started understanding more and more. So in 1987, Di Franzo described the trivalent beta cell dysfunction, muscle and hepatic insensitivity to the glucose lowering effects of insulin. It was postulated that insulin resistance at the liver contributes to the fasting hyperglycemia in the early stages of type 2 diabetes. Beta cell dysfunction and insulin resistance at the level of skeletal muscle promotes hyperglycemia in the post-absorptive state, a defect that is demonstrable on the standard oral glucose tolerance test. So this is where our favorite metformin, it addresses the three aspects of type 2 diabetes, which is very important, which we all know. Then came the fourth one, that is the disharmonious quartet. You can see here, apart from the three, you can see the fourth one on the right top corner, that is the increased lipolysis, that is increased free fatty acid. So you can see here, from the left hand side, you can see the top, the normal adipocyte, the excess energy intake leads to hypertrophic adipocyte, that is impaired lipid metabolism, altered adipokine secretion, immune cell infiltration, inflammation and insulin resistance, leading on to lipid accumulation, inflammation, insulin resistance in liver, and lipid accumulation and insulin resistance in muscle as well, because of the lipid spillover and the systemic inflammation. So disharmonious quartet is a bad tune for diabetic patient. So adipocytes are resistant to anti-lipotic action of insulin. This leads to increased liberation of free fatty acids in the fasting state. Excess circulating free fatty acids promote hepatic gluconeogenesis, hepatic insulin resistance at the level of skeletal muscles, and impairs insulin secretion. So dysfunctional adipocytes produce an excessive amount of pro-inflammatory adipocytokines at the expense of more insulin sensitizing adipocytokines such as adiponectin. The next one was the sixth region, that is the quintessential quintate. So this is where the decreased incretin effect came into the picture. So in type 2 diabetes, you can see on the left hand side, this is what you are seeing is the healthy persons, how the incretin effect is reduced. You are seeing on the right hand side in type 2 diabetes. So quintessential quintate acknowledges the contribution of the gastrointestinal tract in the pathogenesis of type 2 diabetes. An oral glucose load stimulates more considerable increase in the insulin secretion compared to an intravenous glucose bolus. So indeed, the incretin effect occurs as a result of two critical peptide hormones secreted by the digestive tract, that is GLP-1 and GIP. So GLP-1 secreted by the L cells of the ileum is awfully inadequate in patients with type 2 diabetes. GLP-1 is therefore unable to inhibit the secretion of glucagon. So GIP is secreted by the proximal small intestine. On the other hand, is increased but is unable to mediate its target organ effect on the pancreatic beta cells. So this is where the GLP-1 agonist works on the pathophysiology of type 2 diabetes. Next is the cetaceous sextate. So pancreatic alpha cell dysfunction leads to significant hyperglucogonemia in the fasting state. So this is an essential cause of fasting hyperglycemia. So you can see here how the 3 plus 3, 6 reasons are there. Then you can see that the area of alpha cells is increased in type 2 diabetes. When controlled to the control of the green, You can see in type 2 diabetes, the alpha cells is increased in type 2 diabetes. So this is where the other molecules comes into the picture. Next is the septicidal septate, septidal. This is the seventh reason you can see here, where the renal glucose handling, which gets altered, comes into the picture. The SGLT2 and the SGLT1 transporters present in the proximal tubule of the kidney reabsorbs all the filter load of the glucose in the proximal tubule. This effectively prevents glucosuria. Interestingly, the upregulation of SGLT2 transporters due to chronic hyperglycemia leads to a maladaptive state in which renal glucose preservation further aggravates diabetes. You can see, we all know about this because in the past 5 years, we are using the SGLT2 inhibitors, which is a blockbuster molecule of the decade. You can see how this particular molecule is acting, and we know how much beneficial cardiovascular benefit you are seeing and the renovascular benefit you are seeing with the various SGLT2 inhibitors. So the last and perhaps the most important player to be implicated in the pathogenesis of type 2 diabetes is the brain. So this makes the ominous octet. You can see the 8 reasons now. 8 reasons proposed by DiFranzo, that is the ominous octet. So ominous octet of type 2 diabetes was proposed again by DiFranzo in 2008. It encompasses 8 pathophysiological perturbations underlying the onset and persistent of hyperglycemia in type 2 diabetes. The appetite suppressing effects of insulin are significantly impaired in type 2 diabetes. So the functional MRI studies have demonstrated dysregulation at the key hypothalamic centers responsible for appetite suppression. You can see now in this slide the various molecules on the left hand side and the pathophysiological, that is the ominous octet on the right hand side, and the molecules we can see on the left hand side in which particular part it addresses the pathophysiology of type 2 diabetes. This is one molecule, pramlintide, which is going to come, it's available in US, not in India. So if you take the pathophysiology of type 2 diabetes based on ominous octet, you can see in this slide on the right hand side, you have to go from down, you can see the liver. On the left hand side, you can see the alpha cells leads to increased glucagon secretion, decreased glucose uptake by skeletal muscle, increased lipolysis, increased glucose reabsorption in PCD of kidney. On the right hand side, you can see the beta cell, which we know that there is an decreased insulin secretion, increased hepatic glucose output by gluconeogenesis and glycogenolysis, dysfunction of neurotransmitters, and decreased incretin effect. So same, based upon this simple ominous octet pathology, you can see the various molecules revolves around that. So this is where we have understood the pathophysiology of ominous octet of type 2 diabetes. Is this the end? That is the question. So if you see the summary of this ominous octet, the traditional triad has become the ominous octet. So is there only 8 reasons are available? That is the question always. So you can see ominous octet dictates the multiple drugs in combination required to correct the multiple pathophysiological defects, treatment based upon the reversal of known pathogenic abnormalities, not simply on reducing the A1C. Therapy started early to prevent a slow progressive cell failure that already is well established in IGT subjects. So coming beyond, if you take the ominous octet beyond, like only 8 reasons, what is beyond ominous octet in the understanding of type 2 diabetes? So now it has come from ominous octet to dirty dozen. That means 12 reasons are there in the understanding of pathogenesis of type 2 diabetes. So the addition of 4 well-known hormones to the list of players in diabetes to bring the number to 12. All 4 hormones have adequate biochemical, epidemiological, observational, or clinical support to merit the inclusion in the list of dirty dozen of diabetes. So which are they? That is the catecholamines, that is the including dopamine. You can see the therapeutical role of catecholamines. I am sure in the future this is one of the molecule which is in the pipeline which will address the type 2 diabetes. Vitamin D, one of the hormone which is implicated in the various aspects of type 2 diabetes, both in type 1 as well as type 2 diabetes. If you take cardiovascular disease, if you take any parameters, vitamin D plays an important role. In the same way, in type 1 as well as type 2 diabetes, vitamin D role we are already using in our clinical practice, but this is one of the factors which is implicated strongly. Next is the important another hormone, that is the testosterone. It is postulated to impart a profound effect on insulin sensitivity, and its deficiency alters the several metabolic parameters linked with the emergence of type 2 diabetes. So third, National Health and Nutritional Examination Survey found that men in lowest free testosterone tertile were 4 times more likely to have type 2 diabetes than those in the highest free testosterone tertile. So beyond ominous octet, as we accept the existence of the dirty dozen and perhaps the precarious 13, that is the 13th reason, precarious 13, that is iron is included, we need to utilize every preventive and therapeutic strategy available to us in order to halt the diabetes pandemic. You can see in this slide, looks a busy slide, but you can see the iron metabolism in regulating the insulin secretion in the pancreatic beta cells. So even the iron cells, I'm sure in many of the cases you will be using iron infusion, especially in heart failure or any other condition, the iron infusion has become a part of the treatment. In the same way, in the coming days, we'll come to know more about the iron metabolism and its implication in the management of type 2 diabetes. So coming from dirty dozen, so if you take, it is going to be sweetening 16. So that is the 16 reasons. So 20 years back we had only 3 reasons, now we are talking about sweetening 16. So almost a teenager. So sweetening 16 is there. So that is one of the understanding where 16 reasons are coming to the picture. You can see in this particular slide, if you take in the center hyperglycemia, how it revolves around beta cell, alpha cell, intestine, liver, skin, adipose tissue, kidney, skeletal muscle, brain and testes. So various aspects has been coming into the picture, and as the digital technology is improving, we are understanding in the same way the pathophysiological aspect of type 2 diabetes. So once you are understanding the pathological aspect, it is not only triumvirate, it is not only ominous octet, it is not only dirty dozen, not only precarious 13, now it is also sweetening 16. So more and more understanding of the type 2 diabetes, more and more molecules come into the market. So if you take in the future by 5 years to 10 years down the line, there will be various molecules which will be useful in the management of type 2 diabetes. It gives an option to our patient, and in fact it helps in the management of type 2 diabetes, and it will be easier to the patients as well. If you see the SWOT ADA algorithm, you can see in this the lifestyle plus metformin was there. You can see on the tier 1, on the right hand side you can see the tier 2. This was 2003 ADA algorithm. So what it says, HbA1c more than 7, not controlled on lifestyle metformin, add sulfonylurea or basal insulin, add glitazone, 5 glitazone. So that was the situation. If you see this new ADA algorithm, I am sure all of you are aware of this new ADA algorithm. You can see once the patient not responding to lifestyle and metformin, we have a plethora of molecules are available which are most evidence based depending upon the overall associated medical condition of the patient, whether it may be ACVD, whether it may be CKD, whether it may be hypoglycemia, whether it may be cost factor. In all those aspects, the ADA has addressed this, and accordingly the molecule has been suggested. So the possible newer therapies in type 2 diabetes, ladies and gentlemen, you can see on the left hand side it is the present therapies. On the right hand side you can see the possible future therapies. So this is an important main question for the PG students actually. Possible future therapies in type 2 diabetes if we take, there are so many therapies because we have sweetening 16. That is the reason we have more and more understanding of type 2 diabetes in our clinical practice. We think what are the newer molecules? There are so many molecules. In the same way, the novel insulin delivery routes are also coming. It may be oral, buccal, skin, and novel SGLT2 inhibitors. All many things are coming into the pipeline which will help in the management of type 2 diabetes. So to conclude my talk, this paradigm shift based upon pathophysiology represents a novel approach to the treatment of type 2 diabetes, substantiated by vast body, basic scientific and clinical investigational studies. Algorithm is based upon the reversal of known pathophysiological defects. It has a high probability of achieving durable glycemic control. So take home message is, although insulin resistance in liver and muscles are well established early in the natural history of disease, type 2 diabetes does not occur in the absence of progressive beta cell failure, impaired insulin secretion, decreased muscle glucose uptake, increased hepatic glucose production, and decreased hepatic glucose uptake all contribute. Other factors also play. There is a paradigm shift to the newer molecules. Thank you for your patience hearing. I am on time. If you have any question, you can discuss.
Thank you, Arvinda, for your excellent and as usual talk. Any question from audience regarding? I think we have no question.
Yes, sir. I wanted to, what I was wondering just now, are we really at the point of the focus? Because we don't know exactly what is the real reason behind type 2 diabetes. So we are proliferating like mushrooms, like 660, 80, 20, 25, everything. Just like syphilis, if you remember, our teachers used to teach. The void was filled up with the points. And there are, syphilis is hot, syphilis is kidney, syphilis is this. And finally, when trypanosoma pallidum came, and we know that syphilis is trypanosoma pallidum. So we don't know exactly where we stand today. What is your opinion on that?
Absolutely, sir. That is where, if you take any disease, it is the same issue. Whether it be diabetes, hypertension, COPD, asthma, whatever it is, we don't know the exact reason. So that is the dilemma in medical practice. In the same way, type 2 diabetes is the same thing. It will be going on in the next 10 years also. We are now talking, and now it's talking sweetening 16. There may be another brightening 26 also. So we don't know. So in the same situation will be, I saw some of the people taking photos of the main question of future therapy. That means the people are aware and eager to know about the newer technologies or the newer understanding. Tomorrow if somebody, some of our patient comes and asks to us, doctor, don't tell me all these things. Tell me one reason for type 2 diabetes. We don't have the answer. We start telling the whole reason. We're telling about the sweetening 16. Moment we said, okay doctor, don't worry, give me the treatment.
Yeah, but there's a very important point is there. We can define diabetes in a way that type 2 diabetes is relentlessly progressive and highly heterogeneous.
Absolutely.
Heterogeneous disease characterized by hyperglycemia due to very mix of insulin resistance and beta cell dysfunction. And now which is there? Insulin resistance per se will never cause diabetes. So beta cell dysfunction. We have to put on our mind focus on beta cell dysfunction.
Yeah, the future, if you take the various molecules which are coming into the pipeline, are more and more addressing of beta cell preservation. As you rightly pointed out, the newer molecules are coming about of beta cell preservation. Now we are talking about SGLT2 inhibitors and all. That may be an indirect effect of beta cell preservation. We want more molecules. We say what we are telling at the onset of type 2 diabetes, 50% is gone. We are telling. We want that to prevent. We want that 50% to increase by 70 to 80% so that we have a better control of diabetes. Future is bright. We have to wait, Dr. Supriyo.
We are waiting for that future. There may be a day after a decade or so when somebody will tell me who is saying diabetes is a disease. I still say diabetes is not a disease. It is a lifestyle change. It is a lifestyle change of your soma as well as your psyche as well as your beta cells. So you have to find out that where is the cause. Let us wait another 10 years. RSSDI is going for different researches. Amit is here for digital technologies. one fine morning Amit can come in the picture that here is one molecule which is responsible for diabetes and he will get a Nobel Prize. So thank you.
Dr. Supriyo, I would just like to make one point. Though we don't know what exactly causes, but at least we know that unless and until you have beta cell dysfunction, diabetes doesn't happen. You may be having 100 reasons inside you, but diabetes doesn't happen unless you have beta cell dysfunction. So we need to find so sweet 16 is actually trying to find out why the beta cell actually becomes dysfunctional. So there can be n number of reasons for that. So it is not that we don't know that why the diabetes develops. We know, but we don't know what causes dysfunction to the beta cell. So I think we will become wise in the future. Thank you, Dr. Arvinda, for your superb talk.
Thank you, sir. Thank you.
माइक चेंज कर दो.
That is function So friends, let me introduce Dr. Manohar K, who all the way has come with Dr. Arvinda together. And now after sweet 16, I do not know what sweets things he is going to deliver to us. He is an MBBS graduate of 1999. I think my glasses are not working very properly. In 2009, I think I put he is MD from Bangalore, triple FRCP. Hey gentlemen, postgraduate students, just see the curriculum vitae. Triple FRCP, Edinburgh, Glasgow and London. Understand? Have a clapping here. क्या बात कर रहा है? जोर से बजाओ. And after that, lot many things. He is literally a giant South India group. And he is a well sought after personality for the discussion of the diabetes and all that with Dr. Arvinda, who happens to be our friend, and Dr. Amit we have already seen. So all the three trio over here, it was that earlier tri-octet, no? Octet was reduced to the tries. So this is the combination. I am not going to the details of what he is. He will be coming with his talks. Thank you, Manoj.
Thank you, sir.
Just a minute, Manohar. One thing is very important for Manohar. He is very interested in the bodybuilding and exercises. That is one of the reason I think so. He may not develop diabetes in future. Yes. So
I hope so. Anyway, thank you.
Dr. Manohar, before you start, I would just like to address the audience that Dr. B.K. Singh himself is a very fitness enthusiast. In Lucknow, one meeting of RSSDI UPDA con was there, and he was the first person I met in the gym at 6 a.m. in the morning. So gym was closed, but he went there to open the gym.
Yeah, thanks to the organizing committee and such nice words. Anyway, there are many stalwarts. I'm just a student and a learner, so I always object to that senior consultant. I never acknowledge that. Anyway, very beautiful talk by a good old friend, old not by age, by wisdom. He spiced up the whole arena from triumvirate to sextate to septate to sweet 16. Now I will add some fat in that. So we are talking about lipids and statins. Before that, 2 points. One is muscle is an endocrine organ. Is also gaining a lot of momentum. And myokines are the new endocrine hormones what we are looking at it. Sarcopenia, sarcopenic obesity in the pathogenesis of type 2 diabetes is becoming very important. That's why all the guidelines are saying exercise is one of the most important, especially muscle building ones. That's why maybe I shifted from running to some building, whatever I can do. Nothing, I'm not sponsored by anyone, and thanks for the Bihar RSSDI group for all the good hospitality. And I think I heard the talk of ASCVD by Dr. Singh before this, which had a lot of overlaps. So I will not be standing for too long between you and the banquet. So I heard I'm the last man standing there, so I would make it as short as I can. And we all know CVD is the major cause of mortality worldwide, and we have been moving away from glucocentricity to treat CVD in diabetes also.
Some points like we always believe in fasting lipid profile, at least the general population believes a lot in fasting lipid profile. So sometimes when you say we can do it random, people start looking at you. Maybe he wants the lab to utilize the facility or whatever. Or otherwise you imagine someone comes from a smaller place to a bigger town, has to stay overnight and get a lipid profile. But are they same? We just discussed briefly on that. Non-HDL cholesterol, we always been looking at LDL and so on. Non-HDL lipoprotein little a is not as little as it is mentioned. It is gaining very importance in the management of dyslipidemia also. So fasting versus non-fasting, what is the difference? ASCVD risk calculator. If you look at all the guidelines, they say ASCVD risk score. So how many of you know the ASCVD in the interest of postgraduates, and how many of you open the calculator or the web and do it? So I was always amused that we always talk about it, but how important and how are we doing it practically. But today I will have one good news, where it is only one condition which you need to open the calculator, not in all conditions. So wait for that slide. And LDL versus non-HDL, of course statins, they are the most useful molecule, but also the most controversial molecule, I think so. So we'll touch upon that and what the guidelines focus we'll see. So fasting versus non-fasting, friends, there's no significant difference except for the triglycerides in the non-fasting states shows about 26 milligram per deciliter higher value, and it also depends on what food they ate and how much of fluids they took in. So this is the main difference. Otherwise, a marginal decrease in the non-HDL, LDL and total cholesterol values happen when they are non-fasting and give the lipid profile. So that's important. So Lipid Association of India, they're doing a wonderful job, and what they say is you can alternate. Once if you do the fasting lipid profile, next time someone can do a random lipid profile and be done with that. No need of always doing for the fasting one. So if someone has done a random, next visit we can ask them to do fasting and come and show us. Dyslipidemia is a very important slide again. It is outscored smoking also as the single most important risk factor for ASCVD. This is as per the Inter-Heart study and in the Indian or the South Asian context. So more than smoking, it is the dyslipidemia which is bothering us. And does treating dyslipidemia help? Of course, this slide shows various trials, both in non-diabetic and diabetic, as a secondary prevention, as a primary prevention, and also in the high-risk groups in the primary prevention category, with various molecules, whether it be simvastatin to rosuvastatin. Everywhere, if you look at this relative risk reduction or the hazard ratio, when you treat the patients on statin, is always favorable. Very important, few of my teachers also are there who preach against statins, and we get drawn into the controversy. And if you put all the data, the relative risk reduction of ASCVD when you use statin can vary from 20 to up to 50% relative risk reduction. I think in the interest of time, I'll skip few slides here. So classification, it could be natural or synthetic, and solubility, this is important. Lipophilic, which is atorvastatin, simvastatin, which is routinely used, and hydrophilic is rosuvastatin. That's why many of us prefer rosuvastatin. There's another reason with respect to the side effect, and of course we all know the efficacy is much better as compared, or it is twice as efficacious is the atorvastatin, which is twice as efficacious as simvastatin. So mechanism of action, I think we all know that is HMG-CoA reductase inhibitor here, and now we have one more new kid on the block of bempedoic acid, which was 2 steps above that, where it prevents the conversion of citrate to acetyl-CoA by inhibiting ATP citrate lyase enzyme. So it's just for the information. By doing that, what is the advantage of bempedoic acid is AMPK stimulation happens. We all know statins are associated with new onset of diabetes, and that risk of reduction of the progression to diabetes is much lesser. So some people start asking whether we should consider in diabetics bempedoic acid. It's too early now. The evidence with statins is so hard that we should be the #1 drug which should be used unless someone is not tolerating it. So if you look at the effect of the lipid-lowering drugs, by far the most efficacious lipid-lowering drug, of course, is PCSK9 inhibitor, injectable, expensive, not easily available. Otherwise, statins score over any other drug with respect to the efficacy of reduction of LDL and even improvement of HDL, of which I think rosuvastatin does better than atorvastatin. And of course, even triglyceride reduction, of course, we know fibrates does better, niacin did better, but it did more harm than good, so it was taken off for improvement of HDL and triglycerides. It is not so much more in vogue. Other important thing what we all should know is intensity of statin therapy. Again, dyslipidemia management has progressed from reducing the cholesterol level to reducing the ASCVD risk. So we look at the moderate or high intensity statin therapies are much more beneficial when indicated as compared to low intensity statin therapy. In other words, if you're looking at high intensity statin therapy, again we are left with only two choices, either use rosuvastatin or use atorvastatin. And moderate or low intensity statin therapy, the less potent LOVA, PITAVA, PREVA statins could be considered to be used. And adding another agent, this is again, if postgraduates are there, they can look into this. If you want to add an additional agent and get the benefit of LDL reduction, ezetimibe gives anywhere about 20% reduction. Similarly, by bempedoic acid addition, PCSK9 inhibitor, as I said, is the most efficacious molecule with respect to reduction. You use 50 to 60% reduction of the LDL cholesterol. So it's all based on the risk stratification is what is important. Again, it's a very busy slide and it can be got anywhere. Only thing I would like to emphasize is this extreme risk group on the right bottom there, where category A, category B is indicated, where it shows in these groups, now the LDL cholesterol can be brought down to 50 or below. So even the Lipid Association of India guidelines has accepted that another category of extreme risk category, where they have CAD with another feature of very high risk group or recurrent acute coronary syndrome, then you should think of reducing the LDL to 50 or below. So again, this is the calculator which we use or which we don't use it. It's a lifetime risk calculator. There is a 10-year risk calculator which we can use it. And important parameters, of course, is age, race, blood pressure, total HDL and LDL cholesterol, and presence of diabetes and smoking, apart from hypertension, as the parameters which we look at it. Interesting thing, when I was studying my MBBS, they said don't treat till 190, then they said 160, then they said 130, then they said 100, now extreme group less than 50. So it calls for a lot of controversial things, so I dropped something better. Like after 5 years, if someone comes with a lipid profile, his lipid profile could be same, but we will say guidelines have changed. That time I didn't think that you need a statin, now you need a statin. So this is another thing, changing guidelines. Of course, it's all based on the evidence-based medicine and what we hear. So the good news could be your cholesterol has stayed the same, but the bad news is now the guidelines has changed and you need a tablet for it now. So that's one thing which can confuse us and also the patients. And again, I won't get into this. And also again, European Society of Cardiology, again, what it's in simplified form, it says is the treatment goal is also based on the high risk or low risk or moderate risk, what risk classification you do for the patient. So very high risk, again, they also address the very high risk group as it was mentioned, and we want the LDL levels about 55 or so. So if it is high risk, 70 is okay, moderate risk, 100 is okay in most instances. So this is what we need to keep. So when you look at the patient, you should also see whether what risk category he belongs to. Again, as I said, most potent, most commonly used, apart from PCSK9 inhibitor, which is the most potent, is the statin, and everything starts after that. If you are not under the goal of what is expected for the patient, you can think of adding ezetimibe, and if that is also not sufficient, you can add PCSK9 inhibitor. I have never used it, so you can think of it. And again, intensity of statin therapy. What is high intensity? Where you look at targeting the LDL level reduction to more than 50%. So indications for statin, are you justified? This is the question just to answer the controversies of the statin. On to the right of the screen, you see the 10 years number needed to treat and statin eligibility as per the criteria is what we have drawn. So even with the lowest criteria for eligibility of statin therapy, that is diabetic with ASCVD 10 years risk of less than 7.5%, you treat about 73 patients and you prevent one ASCVD factor. So as a secondary prevention, means someone had a coronary or a cerebral event or a peripheral vascular disease, and you just need to treat 9 people to prevent it from getting one more event of the same. So this is the important slide what I was trying to. There are 4 major statin management groups. clinical ASCVD means they had some coronary event or cerebrovascular event, undoubtedly give it. Age is 20 to 75 and LDL more than 190. You don't have to open the calculator. More than 190, you treat it. Primary prevention in diabetic, the target is 70, so you can still give it. So only one set of these patients is where our calculator is important, what I showed. So in primary prevention, in a non-diabetic, if the LDL is between 70 to 190 or less than 190, we should see whether it fits into the category of requiring statin or not. Again, intensity, I will not bore you again. This is all ACC, AHA guidelines. One important thing is age more than 75, who are not already on statin, you can continue them. But if they are not on statin, you can have a discussion with the patient and continue it. Patients on maintenance hemodialysis, more often than not, are not required to use the statin because it is not proven to show any mortality benefit. Otherwise, in most instances, in the 4 risk groups what you saw, you just have to decide whether it is moderate or low intensity statin therapy. So how do you follow them up? Lipid panel 4 to 12 weeks and then every 3 to 12 months. Responses are defined by percentage reduction from the baseline. So the old LDL report is also important if you really want to look at it and intensify the statin therapy there. So inadequate response, look at the compliance, intolerance, or you can add ezetimibe or bempedoic acid if in case it's available. Now it's available, I will use very few cases. And usually when it came into vogue, transaminase monitoring was indicated but not in all cases, and as a routine for a diabetic evaluation we can do that. So if you are not, how do you prove it? Let's say there is a very interesting data actually on prevention and epidemiology. It was in the European Heart Journal. If someone was indicated statin and they had not taken it, what has happened to them? So that's a very good data that it showed. Most of the times their ASCVD risk worsened when they were told to take statin but they didn't take the statin. So that's another way of confirming that you need to continue to take the statin therapy, and the controversy should to an extent come down on that. So side effects, we all know myalgia, myopathy, sometimes cognitive defects and new onset diabetes. Yes, new onset diabetes, if you look at the statin data, the hazard ratio favors higher odds for developing new onset diabetes and transaminase elevation. It is definitely true, but what they say is the risk benefit ratio favors its utility to be given to the patients in spite of this minor, and there is a lot of skewed data on some show risk, some don't show the risk, but meta-analysis shows there is definitely a higher chance of having statin-induced or new onset diabetes, more so in people with family history or they are pre-diabetic, then you should be much more watchful. So if there is any side effect, try and reduce the dose. Sometimes alternate day dosing can help it, and if not, add ezetimibe, and now we have the new kid of the block, bempedoic acid could be used, and sometimes supplementation with coenzyme Q10 could help. Vitamin D, some people say, but it's not shown benefit to reduce the myopathy or this thing. So in the liver patients with chronic liver disease, again, if the indications are strong, you can use it provided the liver function tests are stable and the transaminases are less than 3 times normal. Otherwise, under careful monitoring, maximum tolerated dose can be given. So when not to start, it's easy. When not indicated, don't start it anyway. If they have severe intolerance, hypersensitivity, pregnancy, lactations, and when there is a CLD but transaminases are more than 3 times normal, or you can't follow up the patients, then don't take it. So friends, in the end, the take-home message is lipid lowering therapy has moved from just reducing the cholesterol to reducing the ASCVD risk. Statins definitely are the mainstay of treatment, and I showed you the big 4 indications. Secondary prevention, definitely use it, and ASCVD risk calculation is only indicated in a non-diabetic where LDL is less than 190. The moment it crosses 190, or if he's a diabetic, most often than not, they require statin. Previously we used to say that aspirin for all diabetics, now possibly it is statin for all diabetics. And new onset diabetes, yes, it exists, but the risk-benefit ratio favors statin therapy. Why does this controversy happen actually? Because of these 2 reasons, and I leave you people to make sense out of it. An ounce of prevention is better than tons of treatment, or primum non nocere, maybe it causes problems, so shall I not use it? So that decision the learned people can take it. Thank you very much for the patience.
Thank you, Manager, for your excellent talk. The House is open for any question or comment. I think there is no question. One question from Amit.
It's not a question, it is just one addition to your talk. You have very well defined that when to start and when not to start. It is equally important to know when to intensify. So most of our patients, this is again a part of therapeutic inertia. We know that there is a therapeutic inertia in diabetes when it comes to insulin. There is therapeutic inertia when it comes to insulin, statin intensification also. So giving a baby dose of statin to a high-risk patient or a very high-risk patient is not going to serve any purpose. So it is again very important for us to know that when to intensify and how much to intensify. So this is just I wanted to add. Thank you, Dr. Manohar, for your wonderful talk.
Now the session is closed. Thank you, Manohar. Thank you, Arvinda.
Thank you, Chairperson, and thank you, Speaker. May I request our first speaker, Dr. Arvinda, to please come on the stage. Dr. Manohar, please join me. I request the chairpersons to honor our first speaker in this session, Dr. Arvinda Jain, coming all the way from Bangalore. A big round of applause for Dr. Arvinda. And a memento for other speaker, Dr. Manohar, who has taken equal pains to come all the way from Bangalore to deliver his illustrious talk. Thank you so much, sir. And may I request the two speakers to honor our trio chairpersons with a bouquet each. Thank you so much, sir. With this, we come to an end of the scientific program for the day. Thank you everybody for joining, and we hope to see you all, especially postgraduates, first thing in the morning at 9. Please come, and we will join for the banquet dinner. Please join for the banquet dinner in an hour or so. So thank you so much for this.